technologist at the hospital laboratory, and today I'll be your chairperson. Chief Medical Officer, Dr. Shara Greenaway, other officials from the Ministry of Health headquarters, directors, heads of departments, distinguished presenters, colleagues, and other invited guests, welcome. Welcome to the second annual Research Day organized by the Ministry of Health Primary Healthcare Team. Upon reflection, the event was well received last year, and so we are here again today. As we are aware in the Ministry of Health, this initiative is geared towards highlighting some of the works that have been done by some of our very own colleagues, as well as sharing this invaluable information with the wider community in Montserrat, those in the diaspora, and further afield. At this time, I would like to acknowledge that the event is being live streamed via the government's YouTube page. So I think this information should be available. And it's also being streamed via channel 96 of Digicel Cable TV. So if you are aware of anyone who cannot be with us here this morning, please inform them of the virtual platforms that are being used to broadcast the event. So if we look at the agenda, we can see that today's presentations will span 3 segments. The first of which will look at a few screening initiatives that were taken to gain insight on the development of our island's preschoolers, psychosocial stress factors affecting the government of Montserrat's workforce, and whether or not hosting a health fair is an effective screening opportunity. Later in the morning, after the first break, we will move into segment 2, which is themed Navigating the Trends. That's around 10:35. Hopefully, we can keep to the time. And after the second break, just before lunch, we will have presentations from the third segment that will shed some light on the impact of several interventions on our Montserrat population as it pertains to hypertension self-management, and bringing it even closer to home, one of my favorites, how a 6-week healthy living challenge impacted the health and well-being of its participants. After lunch, we should be in wind-down mode with the final 2 engagements regarding ethics and some acknowledgements and awards. So as you can all see, we have a packed agenda, but it should be very exciting, and it's going to be an informative day. I can see we have the majority of the presenters here with us, and I know they are anxious to get the ball rolling. But before we do so, let's do a bit of housekeeping, because this is important to ensure that we have a timely flow of the presentations and that everything runs, quote unquote, smoothly. So first off, each presenter has been allotted 15 minutes to present, and I will indicate when you're coming to the end of this period. After each presentation, we will have a brief question and answer segment, a little period for presenter audience engagement, and questions from our online viewers are also welcome. And I think we have someone from the technical team to assist us with that. Importantly, movement between presentations by members of the audience should be kept at a minimal. I know we're healthcare professionals, and there are times we would have to get out for urgent reasons, but try to do so as discreetly as possible. And another thing, for the cellular phones and other similar devices, please ensure that they're on silent or vibrate so that we do not have interruption of our presenters. Right? So at this point, I am very eager to hear what our presenters have to say. and I'm sure that you guys are too. So without any further hesitation, I would like to invite our first presenter. She is Dr. Paz. And she is the pediatrician that is attached to our ministry. And she's been with us for just over 2 years. She has a range of experience, 25 years working experience, working in multicultural settings, including South Africa, other UK overseas territories besides Montserrat. And she has a special interest in community health and early childhood development. So I'll ask Dr. Paz to come and deliver her presentation. Let's welcome her, please.
Thank you, everybody. And I have come with my toolbox. So, technical team is going to help me with my presentation. And thank you for introducing me. So that saved me a little bit of time of my presentation. All right, so this study is about early developmental screening among the preschoolers in Montserrat, which means that, down, the next one will be down, okay. So basically it's about screening every child that comes to my consultation for any concerns about the development. So when I say preschoolers, we'll be referring of children under 5 years old. This side? Oh, okay. Okay, so every encounter with a health practitioner is an opportunity to screen the children for any type of development and general health. So I'm using the scheduled 1 year and 2.5 years evaluation by the pediatricians, any other opportunity, also visiting preschools. Also I've received some referrals from other practitioners, nurses are becoming aware, some teachers are pointing some concerns, and lately a couple of parents, not too many, but have approached me and I said, I think there is something not quite right with my child, so this is the opportunities. Okay, all right. So what do we do during the consultation? We obviously, you go to the doctor, you expect the doctor to do a full medical examination, top to toe, and we check the heart and everything else, but beyond the stethoscope, we also check for gross motor skills. And gross motor skills is like walking and running around and jumping and things like that, according to the age. Fine motor skills is when you refer to touching and doing things carefully and just becoming more hand-aware and fine things. So language and communication is not only the speech. Children communicate in different ways. They have a nonverbal language as well, and they also have a play language. So that's part of the evaluation. Social interaction and behavior is how is the child aware of the surrounding, how does he interact with strangers, with other peers, with parents, and how do they behave. So obviously, that takes a while to get to know the child, but we have some techniques to do so. Okay, so for those that don't know, we don't have 5 senses, like the 5 on top. We also have other senses. So apart from the vision, the hearing, the smell, the taste, the touch, we also have a sense of movement or balance. So we tell us, like you are sitting right there, without looking at your leg, you know that your legs are flexed and your knee is flexed. That is an awareness of your own body, which is, that one is body awareness, it's a proprioceptive, so you know where the body is. And there is another sense of internal sensations. You know when you are hungry, you know when you are thirsty, you know when you want to go to the toilet. So those internal sensations are part of our senses as well. So we are looking at all these sensory issues as well that could present as early at the preschool age. And on the right-hand side, you will have a diversity of conditions that are related to sensory integration with all these 8 senses. So no more 5 senses for everybody, we have 8, okay? So at the age of between 1 and 2 years, we're expecting a child, and this is a pediatrician being strict, and I said, this is what I want a child to do from 1 to 2 years. So that will be sustaining eye contact, sustaining, not quickly looking at you, sustaining, and that happens very early in life. Even when the babies are breastfeeding, they look at the mother's eyes. So the children should continue looking at people's faces and eyes. So respond to his name, Peter, and Peter turns around, and Peter knows we're calling Peter. Smile and laugh to the caregivers. So they're usually very fond of somebody, usually it's a caregiver, it's a mother, it's a father, that they're laughing and they really get excited when they see them. Pointing and waving, that is a very important one. It's not about holding and doing like that, it's that finger, that pointing at the age of between 1 and 2 years is great. And waving, that waving goodbye, not like that goodbye, is bye-bye. And could be also like that, but with a meaning of goodbye. So following basic instructions, come here, take this, where's the ball, things like that. Playing turns, like rolling a ball, rolling a card, my term, your term. And employ some imaginary play, like pretending and drinking tea, stirring a cup, cooking, pretending. And call a name of a person or object. It doesn't matter if they don't pronounce it well. They might call Dada instead of Mama or Tata. That M is very difficult to pronounce. So Tata, Kaka, Waba, Wa. It doesn't matter, but it has to have a meaning. Gogo, Tutu, whatever name is with a meaning. So I'm going to select a volunteer. I select is not a volunteer, but I'm calling Josephine. And I'm going to give you a little demo what's happening in a pediatric consultation. Josephine, I'm going to change her name just for this presentation. Today is Annie. And I said, Annie, come here. Annie's here. So I'm going to show my toolbox. And in my toolbox, we got different things, but I'm not showing everything to Annie. So I said to Annie, Annie, ball for you, for me, for you, for me, for you, yay! So Annie is also clapping, and she's doing what I want. So then I take the ball away, I'm playing with Annie, and Mommy is usually behind me, she's looking, and Annie doesn't feel very left behind. So I said to Annie, Annie, look what I've got here. I'm not pointing, I'm just talking to her. Look what I've got here. Annie, oh, that baby is so hungry. But even whatever, Annie was going to take the baby, she's going to feed the baby, is not feeding herself, baby or dolly or whatever. For those that don't like boys playing with dolls, we have also Teddy, anything that she makes, yeah. So whatever she does with a meaning can also be the brush, can also be the cup, but she's having a meaningful play with these dolls. So somehow, I'm taking that away, and I said, oh, Annie, yay, yeah, and Annie is also very happy about it. So then I come a little bit further, and I'm going to put some blocks out, and I will say, look at these blocks. Can we build a tower? Let's see, Annie, can we do something? I can also probably do it from one side, but at the age of 1 or 2 years, you should be able to do at least 3 blocks on top of each other. But suddenly something is going to happen. Uh-oh! And then Annie goes and look at me, look what happened. And then she will pick up, and Annie, please pick up that, yes, yeah. When it's a bit older, we will be talking about the blue one and the green one, so we make it more complicated about the age. But that's basically what it is. So my short demo now will be, this is Annie being the child that the pediatrician wants to see all the time. So there is some variations, which is not necessarily a bad thing, and we don't call normal or abnormal or anything like that. Some children develop differently, and some children might have some atypical development. So Annie, we are going to see, look what I've got, Annie. I've got a ball. Annie, Annie is not looking, she's busy. Annie, look at the ball, yay, Annie. Annie, I have to pick up my own ball now. And then Annie will say, I'll try to say 1, 2, 3, the ball, and Annie's busy with the ball, but she's not sending it to me. So the next one will be, Annie, look what I've got here. Look what I have here. And Teddy is so hungry. Oh, this is so nice. I think I'm going to do something with that. So Annie is playing with the brush. She's hitting the brush. She's maybe busy around, but she is not having a meaningful playing. And then we go quickly to the blocks, because they are already telling me they're taking too long. So we are going to go with the blocks, and she will do something with the block, light them up, but not really building the tower that I wanted her to build. And suddenly the block will fall, and she was going to ignore it. That is one of the ideas. Thank you very much, Annie, and they are rushing me now. So this is 2 concepts that I want you to understand, so I can show the result of my study. So developmental delay is this gross thing that is about language and motor, and the child is not walking at 1 year, the child is not saying any word, he's not comfortable with strangers, and the other one is the criteria for atypical development, which is this deficit in the social communication, interaction, restricted play, restricted movement, a lot of frustration, a lot of not understanding. So that is 2 different things. One, it will be delay, sometimes we call it challenges, and the other one will be atypical development. So this is, I want to quickly go to this so you know what exactly I'm looking for. I'm looking for red flag of different sensory processing disorders. So tendency avoiding interaction, difficulty in playing and paying attention, limited eye contact, repetitive statements, play of behavior, do the same tower over and over again, and doing the same line the car, things like that over and over, those like the boy in the picture. And the one for language is problem following directions. Come here, sometimes you have to call a child, Annie, I feel Annie doesn't hear me, but she does hear me, because when I bang the door, she does like that, but she's not responding to me. Echolalia is like, it's repeating what you say, not only bye-bye and bye-bye, also good morning, good morning. So, are you well? Are you well? You know, that's a little bit older when they have more complex language, but many children tend to repeat what you say instead of interacting in a conversation. Sometimes this frustration with a lot of, some people call it tantrums, sometimes it's just meltdowns that they're unable to verbalize what they want, so they can't do different things and, you know, be very frustrated about it without being able to communicate it. Then other sensory and motor, the child's not pointing, avoiding hugs and light touch, poor coordination, and self-stimulating behaviors. And this last one, we refer to children that we get frustrated and usually do something like this, or they can be flagging, or they can be speeding too much around. That is something that we could be concerning about the development and the sensory processing. So the objective of this study is to first, just a descriptive study, and just to share with you the findings with developmental assessment of children under 5 years. And just mention some strategies that you could be doing in Montserrat Island to enhance and include and make all children inclusive, all inclusion of neurodiversity, that's what I mean. So, and later on, we wish to do a more analytical study about these findings to see, dig into demographics, details, the client's needs, the parents' details, not named, you know what I mean, like demographic, age of parents at birth, many other things that we want to later on analyze in a more detailed study. So the resources for that have been my personal collection, the Schedule of Growing Skills, which is my toolbox, the report from CHATS, that's a team of specialists from Antigua, occupational therapists and speech therapists, who have come to the island twice, 2022, 2023, and they're about to come again at the end of May. So they do an assessment of these children that I refer to them. And then 6 of our staff members were in a workshop. We will learn a bit about atypical development. So the results of my study, this is what it represents, that I found from February 22 to November 23, 41 children, preschoolers, with some concerns in the development, and with atypical development, 25. So the number of these 26 of these 41 have been assessed by the special team. 15 are still on the list to be assessed. And if you look at the population of Montserrat preschool, this is a data with some limitation. Attending daycare, which is going to say the 1 to 5 years, so omitting those who are not in daycare, is 157, that make us the conclusion that 1 in 4 preschoolers, according to my findings, exhibit some form of developmental delay. And 1 in 6 preschoolers have presented with some atypical development and sensory processing disorder. That it doesn't matter if the denominator have limitations in the denominator, and so is a challenge, is a limitation, but what I can reassure you is that there are at least 41 children under 5 years needing special help. And not to say that after we conclude that in November, I've got an additional 6 more children needing that. So the number keeps increasing the more we look for it. So I'm going to go very quickly. Everybody should know how important it is to do the early screening, how the early you identify an issue, the quicker you can act and the more you can provide. And there is no such thing in medicine anymore that you wait and see with children. We do not wait and see anymore. We intervene very quickly. This is a planning of future analytical studies, what else we want to do with this data, and how we're going to get parents to consent to give us more data to find out what the situation in Montserrat is. And our biggest challenge, what do I do with the children after I diagnose such thing, after the psychologists tell me what, after we identify this, I do the assessment, we can get a diagnosis, what is next, where is our support, where are our therapists, where are our schools helping the children. So the recommendations, and this is just try to summarize it, more efforts for Department of Education, Department of Health, knowing that the needs that we have to work with these children, which is a future of Montserrat. This is our new generation. This is our working class of the future. We need to act now. And so we need budget, we need to consider the disability grant. We will soon going to have the workshop for disability in Montserrat by the social welfare. So we have to be prepared to give a special curriculum, special education for the children in need. And then, muchas gracias. And this is a picture of me taken over 25 years ago with my 3 foster children from South Africa. And I love it.
Alrighty. Do we have any questions or comments for Dr. Paz?
Hi, Dr. Paz. I thought that was excellent. I love your passion for the job. One question and one comment. So, fantastic study. I'm interested in knowing how the government's going to turn that into change so that our children who are going to school, primary schools and secondary schools, actually have access to educational assessments. Because I think there are a lot of children here with special educational needs who are not diagnosed and therefore can't be helped through the system. So, fantastic. My question is, 1 in 4 sounds like a lot. How does that compare to the rest of the region or the world?
Now, that will be part of our future analytical studies. Remember, we have a small population, and we also have a very restricted gene pool, genetic pool. So where incidence of certain things can be higher than the rest of the population. And to mention about the special education needs, last year, a team from the University of West Indies and Barbados came to assess children here. We had a list of 50 school children, and they went through 29 of them with a very holistic and comprehensive assessment that is 9 pages each. School children. But my mission is early intervention. I don't want to get to school without help yet. Okay, thank you. Bamsile.
Thank you, Dr. Paz, and for the very informative presentation. I know we have done some couple of work together in that respect. Just to mention the issue of early detection, what I feel there is need for community education and awareness as part of what you should be looking at next. I know you've done a few things in the past about that. In our previous interactions and fora, we found out that some men and women in the community are either in denial or not wanting to bring these children out to actually come for early screening, and that will probably lead to early detection. So I feel recommendations should include going from community to community to enlighten parents. As in this regard. Thank you.
Thank you for the comments. Thanks to Penny Maloney, sitting somewhere there, we have done some stuff already on the radio and community awareness. Dr. Imara recently spoke a lot about autism. We have announcing the therapy is coming. We've been telling children, and we actually are outreach even to the local churches to talk about, if you have any problem, you go to pediatrician on island, come and see Dr. Paz. The schools, we send pamphlets to school. The Department of Education have pamphlets to school, what to look. Screen time, no, screen time. We've been pamphlets that have been distributed in every daycare center. So we are doing what we can. We need more.
Thank you, Dr. Bass. Excellent presentation, as was said. Do you have any ideas as to why we got such a high number of children coming out in terms of difficulties? Do you have any ideas to environment or biology? Is it the lack of stimulate, or is it something else?
Okay, that's a big question. And then I can say then our next study will analyze contributing factors, and we will compare with other regions. So to make really the statistics very scary, the US says 1 in 64 children will have a typical development, and I'm telling you 1 in 6. So this is huge. And then my personal view is, one, you got health professionals and a pediatrician a little bit looking. The more you look, the more you find. Also our mental health team, the more you look, the more you find. So awareness of the health professionals and the scholars will find more of these cases. Secondly, all over the world, everybody noticed the increase, because in the very past, these children were hidden, were calling not well, they were not coming out, they were in institutions even, because they were not right. Today, we acknowledge them. And the second one, which I've already mentioned, was our genetic pool. Let's say you got a small population with high incidence of cancer, because many people are related and we run cancer in the family, for instance. So all the developmental challenges, including autism, can also be genetic, and we have already know families got more than one file autistic in the family. So that could be as well.
All right, so thank you, Dr. Paz, for your presentation.
Can I go?
Yes, thank you. Thank you for sharing with us some of the developmental milestones that our children 5 years and below are supposed to be meeting. And as you rightly said, our little ones, screening is important because our little ones are important to the future of our society, and we need to be able to detect early so that we can intervene early. So thank you very much. Thanks much to the audience as well for engaging. But for those of you, once you're going to ask a question or make a comment, once you have the mic, please stand so that you'll be visible for the media team. Okay? Thank you. So next up, we have Dr. Bamshile. Yes? Mr. Mr. Bamshile. He is the clinical psychologist attached to the Ministry of Health, the primary healthcare team, and he's been with us for just about 5 years now. He has a passion for mental health, enjoys traveling and socializing, which is also good for our mental health. So without further ado, Mr. Bamshile.
Well, good morning, ladies and gentlemen. I stand on the existing protocol. Workplace health screening. It's a yearly scheduled task for us in primary health care. Health professionals go to private and public organizations to screen for non-communicable diseases like hypertension, diabetes, even assessing body mass index to determine overweight and underweight. About 5 years ago, for us in mental health, we keyed into the already existing protocol in the workplace to assess psychological and mental health well-being. So we thought it would be nice to share with you, to draw your attention, especially service providers, policy makers, public service managers, and the entire public to our findings. In that respect, we tried to gather a data of 6 months long between April and October 2021, and we subject those data to some statistical and empirical analysis. So I'll be sharing our findings with you this morning. It is increasingly being recognized that mental health of employees is a crucial determinant in their overall health. Poor mental health and stressors at workplace can be a contributing factor to a range of physical illnesses like hypertension, diabetes, and cardiovascular conditions. In addition, mental health can also lead to burnout among employees, seriously affecting their ability to contribute meaningfully in both their personal and professional lives. Mental health problems have an impact on employers and businesses directly through increased absenteeism, negative impact on productivity and profits, as well as an increase in cost to deal with the issue. A substantial body of research have demonstrated the links between psychosocial working conditions or job stressors and workers' health over the last 3 decades. Job stressors such as job insecurity, bullying or psychological harassment or low social support at work, organizational injustice, and effort-reward imbalance have been found to affect psychosocial well-being amongst employees. I just quickly like to share our local experience with you, what we've been able to do in the past couple of years. Workplace screening, like we said, is a protocol, and of course, we also key in to assess psychological and mental health well-being. We use the general health questionnaire to assess psychological well-being amongst employees. For the procedure, we explain the procedure of administration of this test to workers when we go to their offices. We ensure that the individual is seated comfortably and has a privacy to complete the questionnaire. A GHQ-12 and a questionnaire about 7 to 8 items containing psychosocial variables are also given to every individual within that time range. Individual is informed that the questionnaire will be scored at the clinic, after which they will be contacted if they have a score of 3, which indicated psychological distress. From clinical interactions over the years in the office, we found out that workers who are either referred by managers or HR or self-referral have reported sources of stressors include the following: relationship with problems with superiors, work-family conflicts, relationship problems with colleagues, performance pressure, poor job prospects, and poor social support. And we found this to have some similarity with a job stressor scale, as mentioned here. Now, because it's a protocol, we screen, and we don't just want to leave them at the level of screening, we manage. Okay, so we also carried out some intervention strategy. After the GHQ-12 is scored, and we found a score of 3 and above, individual is contacted through telephone to attend in person a group psychoeducation session to see areas of distresses or what are the sources of or triggers of their psychological distress. Some other persons prefer not to be in the group. They prefer to be spoken to privately. So it's either through direct telephone conversation or they come privately to assess the psychoeducation. Now, aftermath of the psychoeducation, there may be need to further evaluation for some persons who would have indication for depression, anxiety, substance use, and possibly some mental health condition. So a structured clinical assessment is then undertaken at that particular point, then which will now lead to either some form of individual, group, couple, family sessions as may be indicated. We could also do a referral, especially when we found our needs to order services that would ensure recovery in their point. Doctors, psychiatrists, and social services, nurses, and all that we do refer to. Now, the information that we gathered in those 6 months would attempt to investigate, to come up with a study to investigate the psychosocial correlates of psychological distress among government employees in Montserrat. Our objectives were to evaluate the prevalence of psychological distress among employees, to identify the demographic predictors of workplace psychological distress among employees in Montserrat, and lastly, to identify the social factors that predict workplace psychological distress among employees in Montserrat. A cross-sectional survey was employed for this study. We used a standardized instrument, which was a GHQ, as a measure of instrument, and psychological distress is operationally described here as non-specific symptoms of stress, anxiety, and depression. Describing our sample now, we targeted the sample frame of 957 government employees in Montserrat. 278 were considered based on the sample size calculation as a survey study. We employed convenience sampling based on the fact that we had to key into the protocol. So it's when we get to the offices, those who are available, who are present, and give consent to respond to the questionnaire, we quickly administer to them. Eventually, 198 respondents were found. The figure might be slightly above 198, but because of our inclusion and Moderator, please add 30 seconds to that. So because of our inclusion and exclusion criteria, we found out that 198 were worthy of analysis. Okay? Like I've mentioned, the study was undertaken between April and October 2021. Inclusion criteria is that an employee of government must at least spend 6 months within the government's fold, wherever the posting is. And that person must also give consent to participate in the study. Exclusion criteria, individuals that we have identified already with physical or mental health disability were excluded from the analysis. And the reason is not far-fetched. We want to be sure that the psychosocial factors that were reported to link to psychological distress were not based as a result of the already existing mental health condition or the physical disability. So, JSU was used, a short questionnaire like I mentioned. The content of the short questionnaire include years of service, working conditions, salaries and range, job security, bullying, psychological harassment, low social support at work, organizational injustice and effort-reward imbalance, while also administered part of the questionnaire. Procedure for administration was discussed earlier on. Now, in our sample, 198 respondents, we found out that 60.6% were female, and the mean age was 37 years. 22.2% had an over 20 years length of service. 47.9% earned less than $3,354. 5.6% were satisfied with working condition. 42.4% perceived an effort-reward imbalance in the working condition. 27.8% perceived organizational injustice. Overall, 33.3% showed sign of psychological distress. Logistic regression was done to actually look at the paradox between those psychosocial variables. And these are the findings. Years of service showed statistically significant impact on the participant experiencing psychological distress. More specifically, those that have spent between 11 and 20 years in services had 3 times the odd ratios of experiencing psychological distress compared to those with more than 30 years in service. Participants that considered their work condition not satisfactory had 23 times odd ratio of experiencing psychological distress. Those with fairly satisfactory consideration of their work condition had about 3 times the odd ratio of experiencing psychological distress compared to those that rated their work condition as very satisfactory. Participants that perceived organizational injustice had odd ratio of 2 times the odd of experiencing psychological distress compared to those who did not perceive organizational injustice. Effort-reward imbalance also significantly predicted psychological distress among participants' population. Those who perceived effort-reward imbalance had about 3 times the odd of experiencing psychological distress compared to those who did not feel any imbalance in their reward of their effort. The study has certain limitations. We could not randomize our sampling because of the protocol of workplace screening. We must move within the protocol that is established unless a different study would tangent apart from that to now specifically randomize sampling and measure psychological well-being. The study also identified association between variables and the outcome of psychological distress, but not show causation, which would need more research using different methodology. Conclusions and recommendations. Poor working condition is associated with employees' psychological distress. A randomized sampling and a study design that identify both association and causation of psychological factors with psychological distress, causation of psychosocial factors with psychological distress should be considered for future study. Workplace psychological screening strengthens health promotion within the community, prevents mental health conditions, ensure early detection and management of mental illness. Thank you so much.
Any questions for Mr. Bamshile?
Fantastic and well thought out study. My comments were, one, I'm surprised that it's only 1/3 of government workers are experiencing psychological stress, but that is such a significant amount. And certainly I think out there in the community, you see that. You see patients coming in with these problems quite a lot. I was hoping we could peep at your slide with the findings, because if you go back a couple slides. Yes, for the first column, are you saying that people who manage to survive in the service for more than 30 years, by that time, they're no longer stressed? Or is it that the people who manage 30 years are the people who didn't have psychological stress in the first place and have plodded on? My last comment is, oh, I've forgotten it now, sorry, I didn't understand. Oh, my last comment was that the patients who were excluded from the study because they already had disabilities or mental health problems, I thought it would have been interesting to find out whether or not their problems were worsened by workplace stress. So is the system supporting people who already have challenges, or is working in the system making it worse for them?
Yeah, thank you very much. Let me relate with the last, then I go back to the previous one. Yes, what we did, because we have a mental health data in the office, and we know some of those people who would have had some mental health condition that are established, diagnosed, okay? And we see that we're trying to measure psychological distress. On a Monday morning, an individual with severe physical disability, mental health disability, we already know that there will be a report of psychological distress, whether the person is benefiting from intervention or not. So not to color the outcome of the study, we stylishly remove their responses from analysis, okay? Now, going to the second one, the 30 people who have spent 30 years in service, I feel there are quite a few variables that we were unable to assess here that might be responsible for their responses for being satisfactory with the conditions of service. Let's look at it. They are about looking forward to retirement, okay? Compared to those who have spent 10 years, they are young, they are just being exposed to the system. There are quite a lot of agitation. So it's expected that a calm woman, old man who is seated in a corner talking about retirement tomorrow or next week will feel satisfactory, okay? So that might be one of the reasons in a host of other reasons. The other one, you asked 3 questions. Have I related with the 3? Oh, the comments, okay. All right.
Excellent.
There's one that I missed out. I can't remember exactly. Please remind me if I've mixed out anyone. Okay. The people who had disability, why 30 years comfortable and 20 years are not comfortable? Oh, yes. Yes, that might be part of the shortcoming of the study. Now, if you look at it in terms of percentages, we intend to do a survey study. There are 957 sample frame. We've done very well by calculating a sample size of 200 and something that is representative. Even in the eventuality of the analysis, we still found 198 to be representative. If you look at the rule of thumb for survey study, we have more than 25%, okay, of total respondent. And looking at the fact that we already looked at something as a calculated sample size, we had about 69.9% response rate. So we're confident to go ahead with the analysis. So probably if we have done a more expansive survey, extend from 6 months to 1 year, that would have given us opportunity to have more respondents on that study. And perhaps the rate of psychological distress might be more than 3.3%. But for the 6-month study that we have done, those who actually had elevation on the GHQ questionnaires that assesses psychological distress were at 3.6%. And again, let me just say from our personal experiences in the clinic, my colleagues and I who have been scoring the GHQ, inviting people, we seem not to have a very high turnout rate of people who responded to psychological distress. So even if we have expanded in number to about 300 is eventually that we might see fall within a range of the percentage that are reported here. Thank you so much.
Yes, thank you, Dr. Bamshley. Just a quick comment or question I wanted to add, because I know there are persons within our workforce that are struggling silently, and they're afraid to be stigmatized. So what broad strategies or what broad net strategies are being implemented by the ministry to just capture those persons? Because everyone is not going to be able to come out and say, I'm facing this, I'm facing that. But if we have periodic, sessions, what broad strategies are going to be in place to capture those persons who are afraid to come out? And
you have just spoken to the justification of the workplace spending now. We would expect that some persons within the workplace are not interested in coming to the office, even when there are obvious challenges. But going to meet them in their various offices, and luckily enough, if we are lucky to say, oh, you want to participate and consent is given, definitely we expect that that should be expressed in the psychological distress evaluation, and we pick it up from there. Now, there are a lot of flexibility around that. If we call you to participate in a group psychoeducation to discuss the distresses you have expressed, and you said, no, you want an individual session, we quickly latch on that. Say, okay, can we discuss on phone? But even my own method, I like to see eyeball to eyeball, because there are so many things that will be ruled out when we have eyeball to eyeball interaction. So they are encouraged to come along to the office to discuss that individually. And from there, we pick those issues from interaction. Dr. Kowad?
Thank you. Just a quick question on the definitions of terms, because we had some broad definitions there, such as organizational injustice and poor working conditions. I wonder if you came to any commonalities through, because they're subjective, of course, but did you able to come to any commonalities about what people meant when they ticked that they were unhappy with those two concepts?
If I understand you very well, you're trying to ask if those factors that were mentioned in those questionnaire, okay, have been commonized.
Yeah, did you come to an understanding? Was there any commonalities between when people describe what they meant by organizational injustice or the poor working condition? Because you would have seen people in offices, you would have seen people in the environment, and you would have seen perhaps more people, builders and that, so they would have had a different working environment. Was it totally subjective to each individual that they said poor working conditions and we accepted it? Or when you looked at the range of it, was there any commonalities that you could pick
like
out?
I said earlier on, if you look at the interaction from the clinical discussion with workers, there were common psychosocial factors that were reported. But these variables here are variables that have been used in other working environments to test psychosocial factors, okay? And the common one that were reported among workers, even outside Montserrat, were these listed here. So that is the reason why it was inputted in the questionnaire to see how they relate with it. And good enough, some persons were able to relate with those factors, especially as regards poor working conditions. Now, we don't just want to say poor working conditions on the global. Specifically, what are you looking at when you talk about poor working conditions? That is the essence of the variables that are included in this questionnaire.
Hello? Yes. Right, so what I was thinking about was the fact that I'm thinking, right, okay, so I'm an employee who's just completed this questionnaire. I yield some elevated results on my questionnaire results. And now I'm going to be invited to a psychoeducation program or even referred to a psychologist within the Ministry of Health, yeah? In terms of what happens next to those people who want some intervention, the first thing that came to my mind is, how do I say this? Now, there'll be some people that would be very hesitant to come and talk to a fellow employee of the government because we're both working for the same people and the same organization. That's why we have the existence of external employee assistant programs in other countries, EAPs they're called, because they are neutral people. They don't work for the same organisation that you're working for. So there automatically is a greater buy-in to that kind of service because they're going to be seen as neutral and confidential. I would have issues if I had to go and speak to my colleague about what I'm going through when he works down the corridor from me and we're working together as colleagues. I find that's a conflict of interest. I will not have the confidence to be open and honest about what it is I want to discuss because you know who I know in the organisation. Yeah, so there's a problem, and I just wanted to highlight what are we going to do about that because I think that's quite a significant problem, and so far I've not heard that been addressed.
Thank you so much. Now, I share your sentiments, but again, in our system in Montserrat, it's not absolute. It's not absolute in the sense that the human resources managers of government organizations have referred colleagues who necessarily don't work within the health sector for some workplace conflicts in the past. Even within the health sector, I remember there are 3 departments that I don't want to mention that I have worked with in the past in terms of relationship at workplace. So there seems to be a good turnout of expressing themselves and talking about what they are experiencing amongst colleagues. The senior managers have also referred employees who seem to be difficult at work. And this may be due to either problems between colleagues and all that. Now, lastly, some persons would not want to, and you mentioned the employee assistant program, which we all know that will cater for the aspect of confidentiality and, of course, resolution of issues that people are having amongst themselves. Yes, but it's a private thing, and I think government can look into the direction. In addition to the psychologists and professionals working in the office, they can have a professional in the community that is basically centering on employee assistant program, and I think that will be addressed through that.
So we'll take one more comment or question, please.
Okay. Thank you, Mr. Bamicheli, for your presentation. I think it was a timely one. My question is relating to healthcare workers. During the COVID-19 pandemic, a lot of our staff, especially our nurses, were under a lot of stress because I could recall when they had a lockdown, those were the essential workers that had to be out there working. And during that time, you had a lot of fear, especially of COVID. I just wanted to ask if any of the healthcare workers were captured in your study, and if not, because Mrs. Daniel Bourne mentioned about persons suffering in silence and do not really want to come forward. And I think that, especially with our staff shortage, I think there is a need amongst our nurses, our healthcare providers, for something like this. So just my suggestion, comment, question.
Thank you. Noted. Some were captured. I remember as we opened a hotline for community members, I realized the fact that some nurses and doctors or anything, I'm also included, I worked during the COVID-19. The only difference is that I have not been able to speak to anybody about my own challenges, but we'll try as much as possible to relate with a couple of workers who had difficulties during that time. We have tried as much as possible to try to bring on board, but it should be subject to approval of the government to have a psychological workup and intervention program for specific officers working within the government role. The challenges differ. Those of us who are working in the health sector, we have our challenges. Those who are working in the police, in the prison services have their own challenges. The public works, they have their own challenges. But it seems that the police and the prisons, well, the police especially, and the fire services have been able to latch onto the resources we have in the department to talk to them about the challenges and difficulties of their work and how to achieve resolution. So I feel we're crawling and coming gradually. But if government says, look, we want to have an established program that will address psychological well-being and intervention for categories of workers, then we'd have to plan towards that. Thank you so much.
All right, thank you very much, Dr. Bamshley, for your very thought-provoking presentation, and to you, the audience, for your engagement. Just a quick reminder. Yes, thank you. Just a quick thanks. That's it. Thank you. Just a quick reminder for the audience that once possible, kindly stand, right, if you're going to engage. So once you stand, then after that, the mic will be brought to you, okay? Once you can stand, please stand so you can be captured on the videos. Okay, so now we are moving swiftly. We're doing good in terms of time. And we're going to move into our last presentation in the Screening to Intervene segment. And this one will be brought to you by our Director of Primary Health Care. I'm proud to say that she was a former medical technologist. And she has a passion for mental health, for public health, sorry. And she was a part of the organizing team for the health fair that was held last year, where we basically had a one-stop shop for multiple screening opportunities. There was informative exhibitions and much more. So I present to you Miss Dr. Dorothea Hazelweek.
Morning, everyone. Morning, everyone. Morning. I can see you. I know you're there. All right. As our chairperson said, we're going to speak a little bit about health fairs and whether certainly the one that we had in 2023 was an effective screening opportunity. Now, to be honest, health fairs get a good rap and a bad rap, right? Some people, depending on where you are, so like politicians, like health fairs because they increase the visibility. They are liked by management, as I said, and politicians, and I've never yet come across a situation where you wanted to do a health fair and senior management said no because it looks good. It looks good in your end of your report that my team did health fair. On the other end of the spectrum, it certainly increases demand on your resources because in one day you sometimes can do a lot more things than you would do in an entire quarter. You can miss your target group if you really had a target group, and you can frustrate your team. And I have been through all of the above. So in 2023, we facilitated a health fair on I think it was the 8th of December, and we focused on providing to residents screening opportunities. There were a few other things that happened, but the main focus was the opportunity to screen. We're at the end of the year, you haven't yet had your screenings, come to us and we'll provide screening. As part of that, of the evaluation of that process, though, we need to determine, was this really an effective and efficient use of our resources? Because you see, screening does not prevent disease. Let's be clear for those of us who are not sure about that. What screening does, it identifies, preferably in the early stages, disease that sometimes you don't even know you have because you're asymptomatic or you have no symptoms. Or you may already have a particular condition, and you need to screen now for the complications thereof. So in every public health exam, one of the trick questions is, certainly at an advanced level, is whether screening is a primary health care initiative. To be totally honest with you, it is not. Because if you're talking primary health care, you're talking about prevention. Now, it's part of secondary prevention because you're trying now, having identified persons with conditions, to prevent them or certainly delay them getting complications. So Every time the staff come to me and say, let's do a screening, I always say, put on the brakes, hold on here. Let us be sure that this is what we want to do, but we do it. Now, screening is most effective when interventions for addressing the results of the screening are available. Now, there's no point in me screening all of you for, I don't know, I see Dr. Betty right there, so I can't help, for doing pap smears, if we have no means of treating you when we discover that you have a problem. As a matter of fact, it is immoral, in my estimation and many others, to screen for things that you have no intention of treating. So having said that, I think I went through that slide already, telling you what screening is. And there's population-based screening, where you're open to the entire population, and there is targeted screening. So for example, what we did, targeted screening, you may decide, all right, I'm going to go to the Montserrat Diabetes Association, who primarily are persons living with diabetes, and we want to screen them, I don't know, for eye issues. All right? So we advertised, and people came. This was the flyer that went out. It told you free health screening, told you what was going to happen. You can have your eye pressure, your dental checks, and all of those things. And people came. By the end of the day, we had 167 persons who came to us at St. John's Clinic and were registered, because there was a registration process as you entered the compound. Of that number, 140 persons accessed some sort of service. Now the difference here, there were one or two people who accompanied their older relatives, and there were some people who is Montserrat. Something happening at St. John's Clinic, I go in. When you get there, you want to, no, me just come to see what go on. They really didn't want to have a test, and there may have been one or two others who came, and some of the lines were quite long, and so they thought, no, I'm going to go and come back. So they did not, in fact, have a test done. This is a summary. You can see, we did 95 blood pressure readings, the eye pressure readings, weight and height, random blood sugar, HbA1c using a point of care testing. 41 persons found out what their blood group were. Some of them already knew this. 23 persons had HIV tests. 40 persons both had breast examinations and pap smears. 19 men came forward and had blood drawn to do their prostate-specific antigen. The GHQ, the same questionnaire that Mr. Bamishile spoke about a while ago, was administered, and 37 persons accessed that particular service. And as a direct consequence of that 37, 10 persons agreed then and there to have counseling done, and 70 persons accessed some form of oral screening by our dental team. Told you, 657 services if you add them all up as a particular service in one day. Eh? So let's look at individually, blood pressures. So 93 clients. Before the bright people in the room will tell me, you just said 95. Two of those persons had their blood pressure measured twice because the pressure reading was so high that nurse did what is supposed to happen, made them sit for a while and repeat. However, among those persons who've never been, out of that number, 59 clients had never been diagnosed as having hypertension. Now, this is self-disclosure. And of that number, 17 of those persons had a blood pressure reading which was elevated. Among those persons previously diagnosed with hypertension, so they said, yes, I know I have hypertension. We checked their blood pressure anyway. 22 of them had what I would like to describe as uncontrolled readings then and there. As I said before, remember, it's about screening to identify, and it's also about screening to see how controlled you are, because the control is important. Eye pressure checks. If your eye pressure check is high, it's an indication of what? A very bright group. Glaucoma we're looking at here. We found 39 persons with an elevated eye pressure. Of that number, I think one was known already to be diagnosed with glaucoma. 4 persons were referred to the ophthalmologists, and 34 of those were asked to return because various things were happening. People had been doing all sorts of things. Some people were a little bit jumpy when nurse was trying to do the eye pressure and, you know. So the readings, depending on what the reading was, you said, you know what, maybe you could benefit from a repeat, and I can confirm that most of those persons have returned to have the pressures taken. Some were better, some were still high, and they have been appropriately referred. Weight and height. We use the usual body mass index, and 47 persons were classified as based on their values on the day as being overweight or obese. And a lot of us don't like that second word, so you know, you're overweight or you're very overweight. But either way, you're not at what's considered unhealthy weight. Random blood sugar. For a few in the room who may not know, your random blood sugar test, if I stick my finger right now and check it, what you're telling me is what is your blood pressure at this point in time. Blood sugar at the point in time. Very well, you are listening. And for persons who are not yet diagnosed with diabetes, which was 62 of the persons, 3 of them had a random blood sugar level that was considered elevated. And among our known diabetics, again, there were 14 individuals who we would describe as not being within the controlled range then and there, but that could have been due to several things. Because you see, at this health fair, it wasn't any ordinary health fair. We were providing snacks. There were several opportunities to have a smoothie. There was healthy snacks. Some people were, while they waited, were indulging. So a couple of them would look at me straight and say, no, 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 I just had this or I just had that. And they're probably not far from right. So we move on. However, the HbA1c, this blood test now tells you, gives you an indication of your level of control of your blood sugar over what period now? Not right here and now, but over the last 90-day period. And for those who have not been diagnosed with diabetes, 5 of them had results that made reason for concern. And among those who are already diagnosed, you can see, again, another number of them certainly are not as controlled as they could be. Breast examinations. 40 women, as I said, had their breasts examined by a healthcare provider, and we use the opportunity to teach them how to do this for themselves as well. And 2 women were identified as having issues that need to be further investigated, put it that way. 40 women, and I'm told it's not exactly the same 40 and 40. I thought it was the same women, but it's just a coincidence that it's the same number, had pap smears done. And these were done free of cost, by the way. Normally you would have to pay for your pap smear. 2 women were referred then and there, based on what the midwives and the FNP observed. And following the return of the pap smear results, there were 3 women referred for follow-up. The PSAs, there were 3 gentlemen of the number who came, of the 19, who had elevated readings and were certainly referred for, oops, I think I went too quickly, were referred for follow-up. This is the data for the general health questionnaire. As I said before, 10 persons had counseling sessions on the same day. So a counselor, I think at the time he was brand new, he was spanking new and full of energy, because I think he started just before that was on hand among the other team members, and they were able to, 10 had same-day conversations, and 7 persons were given appointments for subsequent dates. 70 persons had a quick screening, an oral check, where between we have 2 dentists, and both of them were on hand. And I wanted to pause right here, where 37 individuals who of that number, we were interested in also looking at what proportion of these persons would not normally be able to access services at the government dental clinic. Because as most of us know, there are certain categories of people who can and those who cannot. And so a few people did not record their ages on their forms. So of 34 for sure, we are knowing, based on the ages provided, that they were not in the age group above 60. They didn't fall into some of the other categories. So it says to me that they at least were able to get a quick oral check under normal circumstances, unless we do a special intervention, they certainly would not have been able to access. And 33% had caries, and we also identified persons with gum disease. So here's a summary again, but this time with the figures. And I wanted to just flag, so with the blood pressure readings, I'm saying you can see the opportunities that are there. Opportunities to help persons with uncontrolled hypertension, as well as the persons who definitely need follow-up and to be monitored. And similarly across the screen. The blood grouping, we have 41 persons with documented ABO blood group. Now, we tested 23 persons for HIV on that day. All 23 tested negative. And as I already indicated, the breast examinations, pap smears, and PSA testing, and the GHQ and the oral screening data are before you. So to conclude, question: did we identify diseases in the early stage or among asymptomatic persons? If the answer is yes, even if it's 1, even if it's 3, then it is hard to argue any other way than we had an effective activity. Were the means of addressing the findings available? And they have to only be available, they have to be accessible. Is that, I didn't hear the same quick yes as I did with the first question. Some findings were addressed immediately, as I said. Certainly the counselor was able to start conversations with persons then and there. Persons were given appointments for follow-up. The ladies with the pap smears, the gentlemen with the PSAs, all of that. And persons were also able to take their results to their care provider of their choice, because we never for a moment assume that people will want to come back to us. So not because you came to St. John's Clinic means that, no, okay, we are the ones who found that you have this. You need to come back to us. No. So actually, if I remember correctly, all 3 of the men indicated, I want my results, but take it to my doctor, which was fine. You give them and you just pray and hope that that is in fact what happened. And it happened with a few other things as well. So I think the answer is yes, that it is an effective means of doing what we also need to be doing throughout the entire ministry. There was one concern I have, though, and that is, just for the record, certainly with the dental screenings. It was not as simple as with the other ones, because they are still within some of our, I think it's in legislation actually, persons who can and cannot access services at the dental clinic. So we have the right, we have the ability, I should say, from time to time to, expose them and to reach out to them and to do a little intervention here and there. But given the reality on the ground where access to dental services is limited, then we have to also be conscious of the fact that either do we really want to continue screening the next time we have a health fair, if we cannot ensure that all those persons I showed you who have caries can be invited to come, or do we actually change the law? And maybe it's a good time, because I know it's a particular year, which I describe as we're in a particular season. Who knows what may happen? So I want to acknowledge the clients who attended and who came out and who spent the day. I'm telling you, folks, there are people who came from morning, and normally you would think, if I come and the line is long, I'm going to turn away. They sat comfortably, and I was feeling bad. You sure you want to go and come? No, no, I'll stay. I'll wait my turn. And some of them spent the entire day. As I said, we did provide refreshments, and we had a little bit of entertainment, and we were playing hopscotch and weird things in the parking lot to keep them entertained. So I want to thank them. And I want to thank Alice for helping me with the data analysis. And then I want to thank the entire team. You know, I talk about Team Awesome all the time. So I want to acknowledge Team Awesome and the other staff who assisted. Ladies and gentlemen, I thank you. And for your, see some of the pictures of members of Team Awesome standing under there.
Any questions for Dr. Hazel Blake? Kindly stand, please. Thank you.
Hello?
Yep.
Yes, hello. So what I saw on the beginning parts of the slides, that somewhere in the 70s%, I can't remember exact number, but 70-something% of people who attended this health fair were female, which means that a very small number were male. And that's a problem, in that we also saw only 19 men turn up for the prostate test. Even in mental health, there is huge issues trying to get men to come and seek about their mental health and well-being. What are we going to do about the physical health, where hardly any of them have turned up here at the health fair, and as I said, only 19 for the prostate? Can we have some targeted intervention that specifically address men? They need to come and get checked out, whether that's their physical health or their mental health.
Agreed. We certainly, as I started at the beginning and saying, this was a general fear. We have targeted men for various reasons. Even in workplace screening in the past, nurses have selected specifically workplaces that have large number of men. So we've gone to Port Authority, we go to Public Works, we go to Flow, for some reason had a lot of men, and Ministry of Agriculture. So what will happen then, though, they do not get the whole gamut, but they certainly get the opportunity, anyway, to have their weight and height, their blood sugar, and now that we have point-of-care machines for the HbA1c, which we did not have before, that can be added. And we've added, as Mr. Bamishile showed, the general health questionnaire. So when we started, it was just the nurses that would go. Now the nurses go along with a member of the mental health team. So that's one way that has happened, and we will continue. I certainly agree with you, we need to target the men. The other thing is, I don't know, how do you get the mindset change? Because there were men there who came specifically because they heard they could get a PSA, which I was happy for. And then I personally try to encourage a few of them, since, well, you're right here, we're doing the PSA here. It was the very same room. I just remember the lab was there, but somebody and Cassandra and I in the room, and because we needed the blood draw specialists. So they were doing that while they were also doing the blood groups. And we were doing HbA1c. And you would say to them, well, we're already drawing your blood. Can't we just check your blood sugar? No. I don't want to know that. There is almost a sense of, if I don't know, it's not wrong. It's not there. So from that aspect, how do you fix that? I don't know.
That's what I'm saying, because especially in terms of prostate cancer, we know that black men, and I guess most of the studies were done in America, African Americans, men are more likely to have problems with their prostate. So, you know, most all men on the island are black, which means they have an elevated risk of prostate.
Preaching.
Right, but also determining what are the attitudes behind why they don't want to come. We have to investigate that.
Agreed. Nurse had her hand up. Nurse. Oh.
Hi. Fantastic turnout for a health fair. I think that is incredibly awesome. So obviously screening programs stop people from dying of diseases that they don't even know that they have. And also it helps to change health policy. So now you know that there's significant dental problems and these persons can't access dental care. and perhaps something will change. I know in other countries, access to dental care is a huge problem. In the private sector, we've done quite a lot of screening programs, and I just want to take the opportunity to thank the Ministry of Health for absorbing a lot of the patients from this. So a lot of the patients who had issues were referred to the gynecology service, referred to urology to have biopsies done. And for men, it is a huge deal. It is a huge problem that 1 in 4 black men will have prostate cancer. And I find that in the screening programs in the community that are private, they are willing to come forward, but we're still finding men with PSAs of over 30, PSAs of over 50, and they have no idea that they have something wrong with them. We had a PSA of well over 300, and these are walking, talking men living in our community who have just not come forward. So I think it is stay on message and push this message that black Caribbean men really need to get their prostates assessed. So fantastic. I hope it's an annual, biannual, or tri-annual event.
You're trying to kill us. Yes,
okay. Pleasant good morning. I'm being obedient. I'm standing. Okay. Oh, okay. Good morning, everyone. To address the problem of men in the Caribbean, it is a major issue. I don't know about the UK. I have some UK persons here. How willing are men to go for screening there? Pretty similar. I wonder why. Pardon? What is your fare? Right, so they have a lot of follow-up programs in your countries where persons are called, you have follow-up, the different persons actually are on the cases of these men. So, you know, it kind of pulls them a little bit more because they're following up with men. Our Caribbean men, well, I find that a lot of them don't show up for medical care unless they are not knocking on heaven's door. So I could, well, suggest maybe for those persons you said were at the port, agriculture, so forth, if somehow a discussion could be had with the employers that it's a part of their contract, whatever it is that they're doing, that they should, it's mandatory, forgive, because, I mean, this is, sometimes it's the only way you can protect your population. You need to do this to follow up. You know, somebody's going to be on your case. Because sometimes it's like you have to be pulling teeth, right? And in terms of the diabetic screening, probably a little reverse psychology might help, you know? And let them know that the dick will stop working if the penis, the sugar is out of control. And seeing as though they really, really love to use that object, it going to drop down, it will have no more use. You need to make sure you don't have sugar so we can fix it before you find that you'll be,
we've tried that.
My dicks are flopping. Takes you. That's my comment.
All right, morning everybody. I would just like to congratulate the team on pulling off this excellent initiative. I'm sorry that I missed it. You know, circumstances beyond my control. Right? And yes, as Dr. Buffon mentioned, it would be good if we can have it annually or biannually. But this would be an opportunity for Mr. Bamishle to maybe screen the staff that was there, because we have limited staff, to see how they feel about it in terms of, was it stressful, how often do you want to do it, and, you know, that opportunity for workplace screening and see how the staff feel about it. But yes, it would be good to have it.
Thank you. We did that. We were ahead of you. We have, of course, at the end of it, we had an internal assessment, and the feelings are documented. The team is willing to do it again. The only question is the frequency. We need to have that conversation. And also certain variations. We looked at different times of the year. We looked at different, what's the word? Target, if we want to do different targeting. We're on it. We will announce at a date to be confirmed. Huh? And what? What did you better be? May I go back to my seat? Thank you very much.
All right, thank you, Dr. Blake, for that overview of the health fair. It's good to know that we would have reached out to those individuals who were identified, and we would have followed up with some of them based on their screening outcomes. The statistics definitely showed that we definitely need to continue to do screening, and that these types of initiatives are needed to capture those persons who won't ordinarily walk into the clinic or to get their health checks done. And obviously, the take home, we need to get the men encouraged to take control of their health. So we are now ready for our first break, and I was told that this is going to be a moving break. Mrs. Maloney? After? Okay. All right, so we're going to have some snacks on the outside. Yes, on the outside. So thank you guys for your vibrant participation so far. Time to have some snacks. We are ready to reconvene. All right. So I'd like to say welcome back. And to those of you who are just joining us, this is the Ministry of Health's second annual Research Day. Before we continue, after such a hefty snack, I think that we need to get our bodies moving and our minds regenerated, re-energized, and I'm going to ask Dr. Shanley Fortune to assist us with this.
Good morning, everybody. So you've just had your snack. We've been here for a while. So what we're going to do is get up and just move a little bit. Let's get energized. Y'all moving, why are you moving so slow? Energy, energy, energy. All right, so I can promise you that it's not going to be very long, but just to get you moving a little bit. So I need you guys to shake. You can shake off the head. Shake on the phone. Just shake it out. All right, guys. All right, so we've shaken it down, the food. Just a little, so just something else I want you guys to do. I need you to do some stretches. So first, we're gonna take some deep breaths in and out. So in, hold it, hold it, hold it, hold it, let it out. So in through your nose, out through your mouth. One more time. Out. Great. One other thing you're gonna do, well, it's a two-part thing. So you're gonna reach up, reach as high as you can, and then we're going to bend. Touch your toes. I know you guys can touch your toes. All right. So you're back, and I'm going to hand you over back to the chairperson.
All right, thank you, Dr. Fortune, for helping us to get our food settled. And before we continue, I would like to acknowledge two comments from persons who are listening to us online. The first being from the former epidemiologist, Abby. She would like to commend Dr. Paz for her fascinating work, and she says that she's confident that the study would lead to impactful intervention that will greatly benefit the children who are affected. And we also have a note from one of our UKHSA colleagues, Renu, and she's commending Dr. Hazel Blake for her presentation and saying that it sounds as though the fair was a success. So we are going to continue now. We are now into our second segment, and I would like to call on the Senior Health Information Officer. This is Ms. Gwethlyn West. She's been with the ministry for over 30 years. She has a passion for research. Since around 2010, she's actually co-authored and authored 9 papers. So co-authored 7, and as of recently, she has done 2 of her own. So this is actually her second time presenting, and I would like to commend Ms. Gwethlyn for always taking the initiative to improve herself so that she can become a better researcher. And she's just recently completed an art training to help with this competency. So I welcome to the floor Ms. Gwethlyn West.
Protocol already established. Good morning, everyone. Today, I will be presenting on the topic, births, their outcomes by time, day, and the year. And this is a retrospective review of maternity and neonatal data on Montserrat. This study is a collaborative effort between myself, Gwethlyn West, Miss Alice Wynn, and nurse Jeanette Lee. So why did we decide to do this study? Well, to our knowledge, no previous national analysis of births by time of day and day of week was conducted. And a similar study was done in England and Wales in 2019. Also, there are some studies that found that of our births, they show greater risk than those occurring during office hours. And this raised concern of our care quality. The objective of the study was to analyze linked maternity and neonatal data for births on Montserrat during the years 2014 to 2023, so that we can inform staffing arrangements and monitor outcomes in maternity and neonatal services. There were 4 objectives. 1, to identify trends in births over the last 10 years. 2, to investigate the timing of births throughout the day and on different days of the week. And 3, to assess how the type of births influences the timing of births. And the 4th one is to determine how the health and well-being of babies and mothers are influenced by the time of birth. As we said, this is a retrospective review of maternity and neonatal records for the last 10 years. All births on island during the study period were included. Only deliveries less than 28 weeks of gestation were excluded from the study. Here are some definitions for the study. Adverse neonatal outcomes is a neonatal admission up to 28 days after birth. And adverse maternal outcome is a maternal readmission up until 28 days after birth. Elective cesarean section is defined as any C-section that is performed on a Tuesday between the hours of 8 a.m. and 4 p.m. The data was analyzed using the statistical software R, and chi-squared tests were used to compare types of birth and adverse outcomes across different shifts at a significance level of P equal less than 0.05. As well, exact Fisher's tests were used for variables with expected outcomes of less than 5. Consent was received from the Chief Medical Officer to conduct the study. Here are some summary of births for the last 10 years. There were 448 deliveries, all of which took place at the hospital. 3 twin sets, 4 stillbirths, and the median age of the mother was 29 years. There were 34 babies weighing less than 2.5 kilograms, 36 teen deliveries, and 40 premature babies. So we will go right into the results. Trends in births for the last 10 years. The highest number of births occurred in 2017, that is 55. And the number of births have been slowly decreasing since 2020, with the lowest number of births in 2023 at 25. The birth rate fluctuated over the course of the decade, reaching 12 per 1,000 live births in 2017, but started declining from 2020, reaching 7 per 1,000 live births from 2023. The chart on the left shows the number of births by year and type of birth. Blue representing spontaneous vaginal deliveries, green emergency C-sections, and pink elective C-sections. The chart on the right is showing the proportion of births by type of birth, and it shows that the proportion of SVD, that is normal deliveries, is being on a general decreasing trend, with emergency C-sections on an increasing trend. Type of birth by day of the week and hour. Tuesdays emerged the day as the highest overall number of births, with 131 deliveries. This represents 29% of all births, and it is expected because Tuesday is the day assigned for surgeries. However, Fridays recorded the highest at 64 births, with 53% of these being emergency C-sections. Sunday had the lowest number of births, 37 or 8%. If we were to remove elective surgeries, there was little variation in the number of births by day. This chart shows breakdown by day and shift. Lowest number of births occurred on Saturday evening and Sunday night shifts. Day shifts constantly had more births than their respective evening and night shifts. Breaking it down further by hour, elective C-sections largely happen between the hours of 9 and 11 in the morning, while emergency C-sections were most common between 10 and 12 a.m., with a second peak between 9 and 11 p.m. SVDs were evenly distributed, with peak number of births at 4 a.m., 7 a.m., and 1 p.m. How type of birth influenced timing of births? All elective C-section procedures amounting to 68 births were conducted during the day shift. Both emergency C-section and SVDs were evenly distributed throughout the shifts, with just a slightly higher proportion occurring during the day. When comparing the distribution of type of births across the different shifts, a significant difference was found for elective C-sections because all occurred during the day shift. There was also a significant difference for SVDs, where births were less likely to occur in the evening shift when compared to the day shift. There were no significant differences in emergency C-sections by shift. Maternal and neonatal outcome. This table shows maternal readmission, neonatal admission, and stillbirths by shift. Maternal readmission rates are relatively low across all birth settings, with the highest rate being 4% of total births in the day and 1% in evening and night. Neonatal admission rates are also low, with day births having a slightly higher number compared to the other periods of the day. Stillbirths rates were overall very low, just 2% in the night and 1% in the day. When comparing the distribution of outcomes across the different shifts, no significant difference was identified. Here are some study highlights. Birth rates in Montserrat have been decreasing since 2020, while emergency C-sections have been on a general increasing trend over the last 10 years. An even distribution of births was observed across hours of the day and days of the week, except for elective C-sections, all of which occurred on Tuesday during the day shift. There was no evidence of differences in maternal readmission and neonatal admissions by shift, and admissions remain low, indicating that pre-discharge care and assessments are of good standard. Even though these three highlights are not linked to timing of deliveries, they speak to high quality of care provided and are worth mentioning. So, the fact that we only had 10%, less than 10% of premature births, this indicates that the antenatal care received by midwives is of good standard. And only 7.5% of all births weighed less than 2.5 kilograms. And this is on par with first world standards and suggests high standards of antenatal care. Maternal mortality remains low throughout the review period, and this is another evidence of consistent high-quality antenatal, intranatal, and postnatal care. So let's give our doctors, midwives, and nurses a round of applause. There were some limitations to the study because of how elective cesarean section was defined. Possibly there could have been some misclassification of elective and emergency C-sections. And pre-existing conditions such as preeclampsia and gestational diabetes that could lead to poor maternal or perinatal outcomes, they were not excluded from this analysis. And not all maternal readmissions or neonatal admissions within 28 days would be directly associated with delivery. Here are our recommendations. Since normal deliveries were evenly spread across all shifts, this highlights the need for the ward to be staffed by a midwife 24 hours a day, 7 days a week. And adequate staffing must be provided on Tuesdays and Fridays, as these were considered peak days for deliveries. Our data show that the majority of our C-sections are emergencies, representing a total of 64% of all C-sections. Therefore, there is need to establish clear criteria for emergency C-sections on island. A reduction in women in the reproductive age, that is 15 to 49 years, was noted during the period 2020 to 2022, a difference of 82 women. This may be due to migration, since they were not reflected in our deaths data. As a result, this warrants the need for clear strategies to ensure population retention, especially for women in the reproductive years, because as we know, loss of women will always result in loss of fertility. The study would not have been successful without the support of the following. I wanted to finish with a quote either about a mother or a baby, and this is the one I found. The only person that welcomes change is a wet baby. Thank you.
Any questions for Ms. West?
Okay, I've got a question and a comment. Lovely presentation. I'm so glad I've got it in papers now that we are decreasing a number of children being born in Montserrat, and I need clients, so I keep saying that. So 35 last year, 25 this year, and then I keep telling my colleagues, please, let's, encourage reproduction, but okay. And the other side is maybe Alice can clarify for me, as I'm doing wrong with statistics. In the recent census that we have with the population census, the population of children is quite high in compared with other regions. So the children are not born here. Some people choose to give birth overseas, and they travel to give birth, and they come with their babies. And some families are migrating to the island with 4 or 5 children, or at least 3. So we have a good number. So if I'm mistaken, please correct me. Under 18, we got 18% of our population are children. They're all my clients. Under 18. So one point to also look at is our teenager pregnancy. And last year, one teenager pregnancy accounted for 9 of the pediatric admissions. When I asked you for the statistics, 9 times she was admitted for issues. To point that teenager pregnancies is difficult to prevent on island because contraception is not free, and because also contraception before the age of 18, you need to have a parent to sign for it. Legally, you can have sex at 16 years old, that's the age of consent, but between 16 and 18, your parents have to sign, and not teenager wants to tell the parents I want prevention, okay? So there is something just to put in the floor for future developments.
Thank you, Dr. Paz.
Well done, Gretlin West.
Thank you, Dr. Betty.
Okay. I was wondering, were you able to ascertain in terms of the number of C-sections that are done? Because you said there is an increasing trend. Were you able to, over that 10-year period, put it in terms of a percentage, what the percentage was over each year, and then the overall percentage, were you able to do that?
Alice, did we? Which one? Oh. Oh, okay. All right. This one.
It's kind of difficult to tell. I mean, you see that you have the different types of deliveries there, but I need an actual figure, like that little green box. What was that? Is that 5%, 10, 15? Okay. That's what I mean. Mm-hmm. You understand? Are you able to give me that information?
No, I don't have it here because we had limited amount of time. We had a table with the numbers, but we had to exclude.
All right, so for future reference, when you're making these type of presentations, for you to see if the C-section rate is high, because you say it's trending. Mm-hmm. It could be trending but within norm, or it could be trending and it's outside of norm. It's outside of norm. It means that more C-sections are being done than necessary, which means you'll have to go back to the drawing board and see why the C-sections are being done. Mm-hmm. So for all intents and purposes, you're working with 30%, 25 to 30%. Anything above that is considered excessive. All right?
I appreciate
so
that.
Once you, right, that's what I'm telling you. So once you're in that range, then it's still considered okay. And you also said that you noticed that there's a decreasing trend in births. Mm-hmm. Would you be able to say, and if not, you could probably look into it, whether if that's because there's an increase in use of contraceptive, if there's an increase in persons leaving the island, is it that persons are opting not to procreate?
is it that we are having terminations? That one might be a little trickier because, that might be hard to follow. But the ministry made quite a mammoth of a task to get obstetrician gynecologists on the island. And one of the fears that I remember being expressed to me was that persons were afraid to give birth on the island for different reasons. I'm a warm person, I would like to say. I don't really toot my own horn, but I somehow tend to pull people. So once I'm there, they will come, for instance. I'm imagining that probably with Dr. MoH's is the same, but if you have a decrease, it would be nice to know if it's because people are deciding still to migrate. Is it that they had complications that could not be dealt with on island? Is it that there is an uptake of contraceptive use or people opting not to? If you could get that type of information. Yes.
So let me just say that, I was just going to say that this is a baseline. So
right.
we will use that as an objective.
I realize. That's why I'm pumping
study.
You with info. You see, I'm pumping you up right there. Okay. The other thing is, yes, so I agree with you. The definitions were a little bit off because what you use is what you would be familiar with, in that most times the elective cases are done on a Tuesday. But sometimes, depending on if something is happening, let's say somebody's blood pressure might be a little off, or maybe they're not able to do it on the Tuesday for whatever reason, and you might elect to bring someone in on a Wednesday or a Thursday, right? So it's not only the day, but the conditions and why it was being done. If someone, for instance, say, well, I want my baby to be born on April 1st, because I think that's a special day. You understand? That's still electing too.
Okay. It was just for the purpose of this
I
study.
know, but you just put on there that you want them to be defined properly.
Yes.
Helping. All right? But, emergency cases are done under conditions. And then you have urgent and emergent. So, there's some stratifications. I can help you off the scene. You know what I mean?
I appreciate
right?
it.
Just pointing these things out.
Thank
okay?
you, Dr.
All
Betty.
right.
Thanks a lot.
The tense moment of being questioned
Yes, so we'll
by
take
an
one more.
obstetrician. The tense moment of being questioned by an obstetrician after a birth study could not have been easy. I simply want to congratulate Grethlin for another very well put together study. She's been doing this for a while, and I continue to be impressed with your passion for research and your level of organization, and just well done. I refer to Grethlin as Professor West because of her research work. Thank you so much.
Thank you very much, Dr. Bufang. And Dr. Bufang was the one who really was instrumental in me starting to get into research. All right? So that's why I always respect her. Thank you.
All right, so thank you again, Grethlin. We are moving on. And we are going to call again on Dr. Bamshile to make another presentation. Mr. Bam.
Thank you very much, Madam Moderator. I'm being pushed seriously this afternoon to start undertaking a doctorate degree by tomorrow morning. Thank you again. Protocol already established. Thank you. For us in mental health, we acknowledge the significance of data gathering, especially as relates to planning, policy decisions, and of course for core professionals in mental health, how it will influence our prevention levels at primary, secondary, and so we are encouraged by the ministry to undertake this data gathering and see how we can make some meaningful deductions out of it. So again, I'll be discussing the patterns of presentations at the mental health facilities between 2020, April 2020 and December 2023 in Montserrat. Before I forget, it's important we acknowledge the invaluable contribution of Ms. Alice Wayne, who had assisted us for this statistical analysis. So thank you very much on behalf of my colleagues. Mental health disorders represent an important and growing contributor to the global disease burden. Small island developing states such as Montserrat are recognized for facing unique challenges and opportunities in preventing and managing mental health conditions. Well, as at the time the data was gathered between period of April 2020 and December 23, our community outreach, because in Montserrat we operate community model of mental health intervention. So we have these outlets as our community outreach. And the team at that time constitutes a clinical psychologist and 2 psychiatric nurses. A psychiatrist who carries out once weekly telehealth consultations and quarterly week-long visits is also with us. So some of the outreach of the program that we have undertaken include workplace screening, weekly radio programs by the nurses, and periodic radio awareness program by other professionals. Then we embarked on certain community awareness programs just to educate members of the community in terms of mental health. In 2022, a recent study, prevalence of anxiety and depression, was undertaken by the Ministry of Health and Social Services, where 4.9% and 8.4%, I found that to be a bit disparate, 4.9% and 5.3% should be, was determined for anxiety and depressive symptoms condition simultaneously, while WHO, in a similar estimate for a neighboring country, Antigua and Barbuda, estimated 5.1% and 6.1% respectively for anxiety and depression symptoms. However, that study by the Ministry of Health in 2022 did not cover a lot of scope. There was a limitation in terms of scope coverage and did not explore other mental health conditions or assess treatment coverage. We intend to build on that study in future because that is not taken care of in this analysis. Now, the aim of this analysis is to review mental health presentations in Montserrat to provide insights to policymakers and planners, facilitating informed decisions for improved mental health services and resource allocation. And our clear objectives is, 1, to describe the individuals assessing mental health services, review any changes in patterns of diagnosis and referrals over time. The study population is all individuals assessing mental health services at St. John Clinic and other community services from April 2020 to December 2023. A data set containing all individuals seeking services during the study period was obtained. It was managed by mental health staff who added individuals to the data set as they presented for services. We categorize the diagnoses based on DSM-5 classifications. Now, during the study period, 246 persons assessed mental health services. This chart shows the breakdown of individuals by sex and age at first presentation. Patients were evenly split by gender, as we can see, with 55.3% being female and the median age at initial presentation was 32 years old. This graph is showing the percentage of individuals by diagnosis. The largest proportion of individuals accessing services were diagnosed with depressive disorder, followed by psychotic disorders and anxiety disorders and post-traumatic stress disorders. We can see that the graph is showing the order of percentages there. There were variations in the gender distribution among different diagnoses. This chart now shows the percentage distribution of different diagnoses by gender. The majority of individuals diagnosed with depressive disorders, about 7%, and anxiety disorder, about 78%. Now, in comparison, the proportion of male were higher amongst diagnoses of substance use disorder. The male represents the dark blue graph, okay? Followed by neurodevelopmental disorders, behavioral concern, neurological disorders, and psychotic disorders. The chart shows the gender and age at presentation breakdown of individuals presenting with depressive and anxiety disorder. We just wanted to see gender-based ratio of these two conditions versus male and female. Diagnoses were highest among women presenting between ages 20 and 40 years old, with the demographic accounting for 59%. If you look at the age range, you will see that women between age 20 and 49 had more representation for both conditions. Now, this chart now introduces the age at symptoms onset. We're trying to showcase the delay in presentation here. The disparity between bars, the dark bars and the open one, at age at presentation and age at onset highlight the delay in presentation. We found out that a higher proportion of females aged between 10 and 19 years experienced symptoms onset compared to when they sought health services. That is when they were presented. So there was a delay between the onset and presentation. Now, similarly, we try to look at the diagnosis for male in this data. For psychotic disorder, men presenting between ages 20 and 40 years accounted for a high proportion of diagnoses. The distribution of men with substance abuse was more even across the age groups, with the highest proportion presenting between the ages of 20 and 29, as you can see in the bar chart there. Similarly, there was evidence of delayed presentation amongst adolescent males with psychotic and substance abuse disorder. Believe we'll be thinking what could be responsible for that. For both psychotic and substance abuse disorder, there was evidence of delayed presentation with a higher proportion in the age range 10 to 29 mentioned. In addition, men aged over 50 also show signs of delayed presentation for both disorder. If you can see the age 50 to 59 there, they were delayed. Now, this chart shows you the number of service users by year of first presentation, okay? Those shown in the dark blue assessed service for the first time during the study period, the dark blue, okay? With those in the light blue, assessed service prior to April 2020. You remember that we started gathering this data from April 2020 to December 2023, with the most long-standing service user first assessing services in 1976 from our data. Now, it's important to note that the numbers in light blue now, that is those who assess the services prior to April 2020, will be underestimated based on the fact that anyone who stopped presentation within those years that we have gathered data would not be accounted for in that statistic. So that might be responsible for the underestimation, okay? Now, the mental health services consistently experience a high number of new presentations from June to November 2020, averaging 9 per month. This increase coincides with the onset of the COVID-19 pandemic and the various restrictions that were put in place, such as the lockdowns and curfews at that time. The association between the pandemic and worsening mental health has been documented in literature that we can see. Numbers of first presentation have decreased with 33 in 2021 from that data and 20 in 2023, where it is possible that the initial surge in the mental health presentation in 2020 lead to a subsequent decrease in the new presentation in the following years. However, there may be other factors, such as shift in referral practice and variations in mental health awareness within those study periods. This chart only includes individual. We're not trying to look at the diagnosis by year of presentation from 2020 to 2023. This chart only includes individuals who presented during the study period. In 2020, depressive disorder accounted for the largest proportion, as we've seen, followed by anxiety disorder and substance abuse disorder. Additionally, there were 8 individuals presenting with marital conflicts, for example. That was not taken care of under the diagnosis because they didn't meet the criteria for DSM classification. In 2021, the distribution of diagnosis was similar to 2020 when we look at it by diagnosis, but in the last 2 years, there has been an increase in the proportion of presentation due to psychotic disorders. Now, we might also be beginning to think what might have been responsible for increasing such a disorder. Well, looking at the sources of referral to the mental health facilities, we have a plot showing the proportion of service users by choice of referral. Overall, the most common source of referral to mental health facilities in Montserrat was from self-referral family or friends. This could indicate a relatively good level of mental health literacy within the community, where individuals demonstrate awareness of mental health concern, recognize when help is needed, and take proactive steps to seek assistance. There is evidence, anyway, indicating that some patients postpone accessing mental health services, as we have seen in previous slides, between age 10 and 19. Okay? This is particularly pronounced among adolescent population. Various factors, including stigma, lack of awareness, denial from parents because they constitute age range where people have to take decisions for them, might be responsible for this delay in presentation. Now, we try to look at the variations in patterns of referral across the year, especially from 2020 to 2023. We found out that the surge of presentation in 2020, the most common referral, as we mentioned, is self-referral and family and friends, followed by social service referral with 22% and hospital referral from 17%. The decline in the number of new presentations in 2021 coincided with a decrease in the percentage of referrals originating from some institutions like social services and the hospital. We may need to undertake further study to establish why we are seeing those trends. Okay? In 2023, with a slight increase in new presentation to 20, the primary sources of referral reverted to referrals from friends, family, and self, and all that. Now, we found out that this graph is, this chart is representing individuals with psychotic illness. The vast majority of individuals seen in that 2020 to 2023 were intervened through psychological intervention, owing to so many reasons. It's either their presentation is oscillating between mild conditions or diagnosis that would not necessarily need medication other than psychological intervention. we now see that 29% of the entire people seen were prescribed medication. This individual represents individuals under psychotic illness who are having diagnosis of psychotic illnesses and those with moderate to severe mental health conditions. The vast majority, like I've mentioned, had psychological intervention. Now, out of these 29% that were seen, 68 of those individuals were diagnosed with psychotic disorder. And of course, we have some individuals who also rejected medication. We found out that about 7 individuals were not medicated. Out of that 7 individuals, 3 individuals with psychotic disorder were not on any medication because they refused medication. The others were not compliant with medication. Now, the key findings from this data: depressive disorders, psychotic disorder, and anxiety disorders are the most common diagnoses among service users seeking mental health support in Montserrat. A surge in people presenting to mental health services was observed in 2020. There is evidence of people delaying presentation to mental health services, particularly among adolescents population. Referral by family, friends, and self are most common in Montserrat. Vast majority of the clients who presented within the study period either had mild conditions or diagnoses that need only psychological intervention to achieve resolution. Now, limitations to the data that was just analyzed. This analysis only includes individuals who attended mental health services. It will not account for individuals in Montserrat with mental health issues that have not been reported anyway. The lack of availability of exact presentation and onset of date. We find that mostly in some of the data, especially those data that were, the documentation that were done before April 2020. We were finding it difficult to nip at the bud the age of onset and age of presentation, especially with the age of onset. People who reported in the clinic were not able to give the exact date. So what we did in that analysis, for the purpose of this analysis, is to put the age of onset and age of presentation to be the same day for some of this data. So we may actually see some gap there. Recommendation. Well, we started the health information system about a year ago now, and we felt for future reporting, that will facilitate more thorough analysis and accuracy in our data gathering. Implementing protocols aimed at empowering community members with self-management strategies is also recommended. Encourage ongoing community education initiatives to tackle stigma-related barriers. Thank you so much.
All right, so we'll take a few questions or comments, if there are any, for Dr. Bam. A few, thank you, in the interest of time.
Hi, Dr. Bam Shelley. Nice presentation. I was wondering if you could just clarify some things for me. Okay. There was a slide where you were presenting persons that had delayed presentation.
Yes.
Could you define how you define delayed presentation and what made you come to that conclusion?
Okay, now, like I said, we had so many variables. There was a documentation about age of first presentation. There was documentation about age of first presentation. But we know that the fact that they presented today, Wednesday, does not mean the onset of the illness is today. So we're trying to find the gap between the onset of the illness and the date of presentation. So we found out that the gap between that, some persons, 5 years ago have been experiencing this condition, and why presenting today? So we find information to fill that gap and refer to that as the delay in presentation.
So basically what you're saying is when they present to you, there would have been evidence that they were displaying problems before.
Thank you very much, yes.
And it would have been over a period of time which may or may not be clear. Yes. But you know that something was happening before. That's basically what you're saying.
Yes, yes.
Okay. All right. I also looked at what you said were referrals that would come into you. You have doctor, nurse, and hospital separate. What's the difference?
Well, there are some situations, especially in the maternity clinic, where nurses will do a referral. They were monitoring their maternity clients over a period of time, and they would have responded to a certain questionnaire that suggests that there's likely an indication of depression postpartum. They refer to us at St. John Clinic. Sometimes they're working in the clinic, Salem, Kojoed, and St. Peter. They find an issue, they call and refer. Our sources of referral is not only on paper referral. Most times we get call, oh, Mr. Bam, I'm referring this client to you about so. From the nurses. Doctors also do referral.
So probably it would be clearer if you say clinic versus hospital, because it's probably doctor or the nurse referring from the hospital as well.
Yes.
As I'm saying, it's kind of confusing because I don't think Ms. Gretlin West will take up the phone and say, I'm calling from the hospital and referring Shara Green away.
Yes, we don't have referral alone from the hospital. We have 4 clinics, including St. John. The nurses working at that clinic at any point in time also do refer to us in mental health.
So what you're saying is the clinics, when you say doctor, nurse, you're talking about from the clinics? As opposed to when it's coming from the hospital, the doctors, nurses in the hospital. That's what you're saying?
No. Even
so when you say hospital, who is making referral from the hospital?
Doctors make referral from the hospital.
Pardon?
Doctors. Most of the referrals we found from the hospital are from the doctors.
Okay.
Because they work together. Even if nurses have spotted the problem.
Okay, so when it's coming from the hospital, you mean it's the doctors at the hospital?
Sure.
And when you write doctors, nurses, you mean the ones that are coming from the clinic?
Sure.
That's what I wanted you to clarify.
Yes.
Now, you have a series of what you call unknown, and we noticed that it was trending up over the years. Who are these unknowns that are making the referrals?
Well, what we found out that critical year, you see, between 2020 and 2022, it's a lot for us globally, COVID-19 pandemic. Now, in terms of referral, there are so many sources we relate with. In the clinic, in the hospital, at social services, personal referrals. I'm experiencing this, I report it, I'm submitting myself for intervention. We classify that as personal referral and friends. So it's not necessarily mean that it's the doctors who would make formal referral. There are avenues where other professionals and even private individuals, managers from offices
that,
will make referral.
but you have a category in unknown. Is it that they just walk in?
Well, unknown will now mean that in the past document or documentation, we are unable to pinpoint exactly who did this referral.
Oh, okay.
So, when we are analyzing the data, the variables we have put together, we are able to gather from documentation who actually did this referral. So we keep it as unknown. Okay?
Right, because you know that is increasing. It's becoming more and more common that you don't know where it's coming from.
Remember that we are analyzing this data in retrospect. We do not have opportunity to keep the person before and say, oh, remind me, how did you even get here again?
Okay.
So we try to sum up that data and elicit a lot from the data we have gathered. Okay? So that may be the reason why we have unknown. Yes, Dr. Imara?
Yes, hello. Right, so I want to comment on, well, first of all, I want to find out where are we getting our data from about these mental health conditions. Are we pulling it from the monthly mental health reporting form? Is that where it's all coming from?
Repeat that again.
Where are we getting our data from about who has depression, who has anxiety, who has this, who has that? Is it all coming from the monthly mental health reporting form that all our clinicians are required to submit every month?
Well, we relate with all data that have confirmed diagnosis that we have gathered.
Yes, but are we pulling it from the... You see what I mean, what I'm talking about? Are we pulling it from the reporting form that we submit? Right, so it's coming from there.
Yeah.
Right, so the issue then is the fact that we are only allowed as clinicians to ascribe one mental health condition per client for the purposes of that form. For example, if somebody has anxiety and depression, we can't note both of those in the one client. We have to go with the predominant or the primary, that's how it's kind of called and couched, in terms of how we're going to assign what mental problem is for what client. Agreed? Right. So the problem is one of comorbidity and dual diagnosis, which is not being captured. Because we are forced to only pick one disorder per client, that is automatically missing out a whole lot of other important data, where typically we know, especially in mental health, that comorbidity and dual diagnosis is actually the more common presentation. People are rarely come in with a pure form of mental problems. Anxiety and depression are very much known to be correlated. If you have one, you likely have the other. If you are depressed, you might also be self-harming. But in the way that we're recording data, we can never get self-harm on the form because we have to put depression as the primary problem for what they're coming in for. So that is a problem, and we need to resolve it because we need to capture the true presentation of our clients. Because if they're coming in as a dual diagnosis, again, that's not being captured. And I want to know how many people are self-harming, because self-harm is something that ought to be taken seriously. It's risky, and we need a risk assessment. But as it stands, we have no way of really capturing that data because everything you put on there, no self-harm was on there, which implies that nobody self-harms, and we know that's not true. Yeah? So that's an issue, and it needs to be resolved, and especially with the self-harm. For example, we know that borderline personality disorder people sometimes self-harm, as does depressed people, as does people who also have autism spectrum disorder. All three of those presentations sometimes come with self-harm. But again, because of the primary diagnosis, which we're forced to do, we're always going to miss people that self-harm, and that needs to be captured. I want to see a change in the mental health reporting form so that dual diagnosis is captured, as well as the self-harm issue, because I think that it will encourage us to take seriously the importance of risk assessment and risk management.
Thank you so much. I just didn't want to interject you. There is a comorbid in our variables. When we were planning this presentation, we agreed with the moderator to stick to a specified time. We have more than 30 variables, more than what we have expressed on that data. So the issue of comorbidity is well captured. Of course, as clinicians, we will not talk about diagnosis without looking at some comorbidity, even beyond mental health comorbidity. There are most of our clients who have physical comorbidity as well. So I can assure you that that data is well captured. The only thing I agree with you that we need to do in future presentations and as we improve is to look at other aspects of variations in this data. We have captured some because of time limitation. This is the best we can present within 10, 15 minutes. There are other, even in terms of assessment, management, what sort of instruments used, what sort of forms of intervention that were used, if there are forms of a group session or individual. We have all that in the variables. So you can rest assured that next time we are pulling out data, we shift our attention to some of those variables that we're likely to express. Thank you so much.
All right, thank you, Dr. Bamshley, for your presentation, which definitely brought out some things that we need to address in-house, as well as, for me, what struck me most was the data regarding the females suffering from anxiety and depression, age range of 20 to 49. I mean, that's us working mothers and, doing so many things. Also, the young people, well, the young males, 20 years to 29 years, substance abuse, psychotic disorders. These are areas that we need to zoom in on. So we have in-house things to work on as well as things to work on as a community. So we are running a little behind time. So we're going to move into our final presentation for segment 2. And I'm going to call on Miss Wynne to do her presentation. She has been with us in the ministry for just about 7 months, and she is the epidemiologist for primary health care. Alice?
Good morning. So this presentation will be looking at leading causes of death and mortality rates in Montserrat. Okay, so why analyze mortality data? There's several reasons. Firstly, to understand health trends, to evaluate healthcare interventions. It's a critical tool in informing public health policy decisions and regulations, and it also helps us to detect disparities within the population. So this particular piece of work was requested to build on knowledge from existing epidemiological studies. There was a study performed last year by Abby Harrison into hospital admissions, and she showed a steady increase in admissions over a 10-year period, with highest growth seen in admissions attributed to infectious disease, neoplasms, and mental health. So a request was made to also analyse our mortality data to see if we were also seeing some similar trends, but also to get a greater understanding of the public health, to inform some of our interventions, and to try and reduce premature mortality. So the aim of this study was to gain a comprehensive understanding of mortality patterns and causes in Montserrat between 1998 and 2022, with the objectives to describe death in Montserrat during the study period by time and person, to examine variations in mortality rates over time among different age groups and sexes, and to identify and categorize leading causes of death and examine any changes over time. So we conducted a descriptive study which included all individuals who died in Montserrat between the 1st of January 1998 and the 31st of December 2022. We obtained mortality data from the Medical Records Department and population data from the Statistics Department. We were given mid-year population estimates with gender and 5-year age breakdowns for each year of the study period. However, there was a 5-year period where breakdowns were not available, so we used data imputation via proportional allocation to estimate the population for this time period. We categorized the cause of death using the underlying cause ICD-10 codes, and we mapped them using the Global Burden of Disease cause list. We calculated mortality rates. So to adjust for the variations in age distribution over time, we calculated age standardized mortality rates, or ASMRs, per 1,000 population. And these were calculated for both all causes and specific causes. We chose to use the Montserrat 2011 population as the reference population in calculating these rates, just because it was the midpoint of the study period. Also in small populations like Montserrat, you can see fluctuations year on year in age-specific rates, just due to random variation. So it makes trend analysis quite challenging. So to try and help with trend analysis, we created 3-year moving averages to facilitate the analysis of trends. So during the study period, there was a total of 1,200 deaths, averaging 48 annual deaths per year. There were peaks of deaths of 59 deaths during 1999, 2005, and, was that right? Sorry, 1999, 2005, and 2019. So we're now looking at ASMR for all causes over time, and you can see that the peak was highest in 1998 at a peak of 15.6 per 1,000. Now, this higher peak is likely because of population movement during the aftermath of the volcanic eruption, which saw a higher population of women and children leave the island. The rate then steadily dropped to around 2002, and since then the rate has fluctuated, and we've seen recent peaks in rates in 2019 and 2022. So now this is the same chart, but we've just applied the male rate in green and the female rate in blue. So you can see that on average, the rate is higher amongst males, and you can see that there was a peak in 2017 for the male rate, and that is likely just because there was an increase in mortality in the elderly population aged 85 plus in that year, and that is a very small population, so it would have a big impact on the rate. So we're now looking at crude rates within the population broken down by age categories. So just to draw your attention to the orange line, which is the line at the top, and this is the 85 plus population. And you can see that since 2007, it's been on a general upwards trend. However, all other age categories have generally stayed consistent throughout the time period. So we're now looking at deaths by three main cause categories. So these are the categories that are defined by the global burden of disease. So in green, we have the non-communicable disease. In blue, I hope you can see in the lighting, we have deaths attributed to injury. And in the orange, we have communicable, maternal, perinatal, and nutritional conditions. And in the purple is ill-defined diseases. So you can see that there's not been a huge amount of variation over time, but the vast majority of deaths have been attributed to non-communicable disease. There is a slight uptick from 2019 in communicable diseases, and that was largely attributed to diseases recorded as sepsis deaths, low respiratory infections, and, of course, COVID deaths. So we're now going to take a moment to look at what the main causes of death were within each of these three main categories. So if we start with non-communicable deaths, they accounted for 88% of the total deaths during the study period, with the main causes being cardiovascular diseases at 39% of total deaths, diabetes at 17%, and malignant neoplasms or cancer at 15%. So just those three disease groupings accounted for just over 70% of the total deaths during the study period. So 8% of total deaths were attributed to communicable, maternal, perinatal, and nutritional conditions, with the largest grouping in this category being infectious and parasitic diseases, although for Montserrat, just infectious diseases, at 3.5% of total deaths, followed by respiratory infections at 2.5%. There was only 0.4% of the total deaths were due to maternal and perinatal conditions. And then finally, to look at injuries, so 4% of the total deaths were attributed to injury, with the majority of those deaths being unintentional injuries, and only 0.5% of total deaths were due to intentional injury. So now we're going to take a moment to look at each of the three main categories in turn and see if there's been any changes over time. So starting off with non-communicable disease. So this is looking at cardiovascular ASMRs per 1,000 population, and they have been consistently higher than any other NCD grouping, and it's largely ischemic heart disease and cerebrovascular disease and hypertension that are the main causes of this. We're now adding diabetes in the blue line, and this shows that since 2012, the death rate in diabetes has been on a general decline, and this trend may signify heightened awareness and education alongside improved disease management and access to healthcare services. However, it's always important to keep in mind when you're looking at trends to think that could also be a change in coding practices. So finally, we're looking at malignant neoplasms, which is shown in green, and the rate has generally fluctuated between 1 and 2 per 1,000. But since 2018, the rates due to neoplasms have been on an increase. And with the year of 2022, there was a record high of 16 malignant neoplasm deaths, which accounted for 28% of the total deaths of that year, with prostate cancer and liver cancer being the two most common cancers during that time period. It's important to note that cancer deaths are often underestimated in Montserrat, as anyone who goes overseas to receive treatment and sadly passes away off island will not be accounted for in our numbers. It's also possible that the COVID-19 pandemic, with lockdown measures and limited travel, made it more difficult for people to seek treatment or diagnostic services for cancer off island, possibly resulting in delayed diagnoses and poor outcomes. But also it would mean that people who normally would have left island would have been counted in Montserrat's numbers. And this is just to show you that the ASMRs of all other NCDs groupings have remained low, below 1 per 1,000 population. So we're now going to look at the sex and age breakdowns for those three major disease groupings. So we've got cardiovascular on the left, diabetes in the middle, and malignant neoplasms on the right, with females in purple and males in blue. And you can see that for both cardiovascular disease and diabetes mellitus, there's a general even distribution between the sexes. There's also quite a similar age structure for those two disease groupings, and they both have a median age of death at 83 years. Malignant neoplasms, you can see that there are a higher proportion of males. At 68% of deaths were amongst males, and also the average age of death was slightly lower at 76 years, with, I think it's 35% of deaths due to malignant neoplasms occurring in individuals under 70 years, which is considered premature death. So now to look at trends in communicable diseases. So this is looking at respiratory infections. So we have the lower respiratory infections in blue and COVID in orange. So you can see that generally from 2012, there's been a slight increase in the number of deaths due to respiratory disease. And we had a particular spike in 2022, which was driven by 4 COVID-19 deaths, and also an increase in lower respiratory infections. Now, there is, despite the fact that there was comprehensive COVID-19 testing on the wards during that time period, there is a potential for misdiagnosis with some of those lower respiratory tract infections may have actually been COVID-19 deaths. And this is now looking at infectious diseases. So 50% of these, or about half of these, were sepsis deaths. The sepsis deaths on here are shown in purple. And since 2018, there has been a sepsis death every year, with a peak in 2019 of 4 deaths. The second most common cause of death in this category was diarrheal disease, which is shown in the turquoise, and there were 8 deaths throughout the period, with the most recent one in 2019. So finally, looking at injuries. So on average, there are 2 deaths annually attributed to injury across the 25-year period, but this has decreased in the last 5 or 6 years. You can see the unintentional injuries, which made up about 75% of all deaths due to injury, were unintentional, with the most common being due to falls and drowning. There were only 6 deaths which were intentional, the majority being due to violence. Of these deaths, I think the vast majority were male. I think 76% were male, and it was a median age of 52. So just to finish off, we've shown a consistent burden of non-communicable diseases, particularly cardiovascular diseases, diabetes mellitus, and malignant neoplasms. And it just shows the importance of public health campaigns and education initiatives to promote early detection, facilitate timely access to healthcare services, and advocate for healthy lifestyle choices, and particularly highlights the importance for supporting initiatives aimed at empowering patients to manage chronic conditions at home or within their communities. So thank you.
Thank you. Comments or questions for Alice, please?
Alice, I really enjoyed that, let me tell you. It was well done. I'm just curious about something in terms of the malignant neoplasms. Mm-hmm. You said that the more common ones were prostate and liver cancer. Could you just quickly tell me what the others were that you saw? Go ahead.
So that was actually just in 2022. Those were the 2 most common. But the most common overall, so prostate cancer, breast cancer, and colon are the 3 major causes of cancer.
Okay, so we know that breast cancer is pretty common among females. We know prostate cancer is pretty common among males.
Yeah.
But you also indicated that there are more males with malignant neoplasm than females. See why the males need to be screened. Yes, we really need to get on top of the men, because I believe part of the problem is that they're not coming in for routine checks. They're not coming, even when they're sick. They're staying home and waiting to knock on heaven's door. Well, thank you very much. I really enjoyed that. Let's see what we can do for a men. That's it.
Hi, thank you. Really enjoyed that as well. My question was similar to Dr. Betty, which you just clarified, prostate, colon, and breast. And locally, we can do something about prostate cancer. We can achieve early diagnosis. We can do something about breast cancer with Pink Ribbon Charity, encouraging mammograms, and then sometime soon being able to have mammograms available on island. Colon cancer and stomach cancer, I think are a big deal here, and very often, like you said, people travel for care, die overseas, and we don't capture that in our data collection. But I think dedicated screening programs to make sure that we're finding these patients with cancer early will be really, really important. Actually having a proper budget to put into doing colonoscopies more regularly than they're presently being done, doing upper GI endoscopies as well. I also wonder if, because a lot of people on Montserrat present with symptoms of end-stage cancer and therefore already have metastatic liver cancer, if some of the primary GI cancers are captured just as a liver cancer in the data, because that's all you can tell. The person now has a big liver, there are mets there, but it's not primary, it's probably secondary liver cancer. So fantastic, it was very good to see what we're actually dying of from current data.
Sure. No, but just to, so a follow-on comment to what you said, Dr. Buffong, we've recognized that the GI cancers and similarly cervical cancer, because after I read the report for this, I did make the comment that something like cervical cancer you're going to pick up early through pap smears, and so you're able to intervene. So the population is not necessarily dying from that type of cancer. For GI cancers, we've started bringing an endoscopic surgeon on island, albeit I think he's only come twice. And so hopefully for next year, we might be able to present some data coming out from that specific intervention. The hope is that at some point we can start that screening program in Montserrat, but we're unable to define what that type of program will be at this point. But just to say it's coming.
Alice? Can we go back to the slide about the, sorry, you want to see me? The slide about there was something about infectious diseases when you were suggesting that some of the deaths were attributed to COVID versus
low
other things, and there was some uncertainty about the coding. Mm-hmm. Help me with that one, please.
So as you can, so in 2022, there was not just the 4 COVID deaths, but there was also an increase in lower respiratory tract infections. So one reason for that could be was that some of these were miscoded as lower respiratory tract infections, when in fact they could have been attributed to COVID. So remember, we looked back in the data and we saw who we thought in public health were COVID deaths versus what there was on the death certification, and there was a mismatch there. So that was saying it could be that potentially.
I think you're being very generous, and I think what we need to say is that there were clearly misclassifications in the death. Alice is too polite to say this, so let me say it. There were some issues that we need to make sure that are not carried forward, because we kept meticulous records regarding persons who tested positive for COVID-19 and persons who were admitted to hospital and then those who subsequently died. And when you compared the data that we had with the death certificates and medical certificate of the cause of death, there was clearly some issues. So we're just flagging that there's a necessity to tighten up on the coding. Maybe it's another opportunity for training and retraining and making sure that we get it right.
Although something I will say is that I think, so ICD-11 is coming into play. I think Grafton's already started using it. And they have an automated tool which you can put all the codes in and it will pop out the underlying cause for you. Correct me if I'm wrong, Grethlin. But that will help in the future with coding, I believe.
All right, thank you very much, Alice, for your presentation. And from my perspective in the laboratory, on the diagnostic side, I could say that the ministry is definitely moving in the right direction in terms of amping up our diagnostics for screening for those cancers and so forth. And with the mammogram program coming on board shortly, we'll be able to do better in terms of breast cancer and so forth. So I think the Ministry of Health, we're doing a good job, lots more to be done, and we will definitely get there. Is it fair to say that we've had a working break, and the next break is only for potty, if we need a potty break? 5 minutes for a potty break? Yes, because we basically had a working break, so 5 minutes it is. Hello. All right, welcome back. And in case you are just joining us, in case you're just joining us, this is the second annual research day put on by the primary healthcare team in Montserrat. And so far, we've looked at researches based on two themes: screening to intervene, navigating the trends, and we are now about to go into the third segment, evaluating the impact. And at this point, I would like to call on my esteemed colleague, Mrs. Penny Maloney. She is the Health Promotion Coordinator, to do her presentation.
Okay, I'm not sure what time of day it is, so good morning or good afternoon. I hope you're not too tired, and you can still focus and pay attention. So, as Ms. Danielle Bourne said, I will be doing an evaluation of the impact of the hypertension self-management training on participants' self-confidence to manage blood pressure. It's a long topic, but y'all understood what it said? Yes, okay, so moving swiftly along. So we know that hypertension is a major concern for Montserrat. We can all agree? Yes? Y'all don't sound sure. Yes, okay. I see the doctor saying yes, so I'm satisfied. So it's a major concern given the high prevalence of the disease in our community. And self-management, I believe, is particularly important in the Montserrat context because of the severity of complications. You can just think about things like stroke, for example, the lack of easily accessible tertiary care for said complications, and there is, of course, overwhelming academic or scientific evidence that self-management is critical to persons living with hypertension. And some of the things it does is that it helps us to adopt a patient-centered approach. A lot of the management for hypertension happens outside of the confines of a clinic room or a doctor's office. Persons have to be in charge, so it's very, very important for them to know how to do so. So the hypertension self-management course, a brief overview, we conducted it in May 2023, and there was a lot of discussion for quite some time between Dr. Hazel Blake and myself about having it done, all the things that we needed, etc. But in May 2023, we were finally able to do it. We had two cohorts. Cohort 1 was a group of 14 special invitees, and they were persons living with hypertension and enrolled in treatment and care at a health center, one of our 4 health centers, and they were identified by the DMOs, and the nurses who see them would have said, okay, these are persons who we believe would benefit from this course. Cohort 2 included 34 persons, 4 of which should have been in cohort 1, but because of scheduling challenges, they were unable to attend that session. 20 persons living with hypertension and 10 non-hypertensive individuals. And for cohort 2, what we did was that we put a radio notice out that we were having this program, and the response was quite honestly overwhelming. Within 1 day of the notice going out on the radio, all the slots were filled, and it really speaks to people's interest in their health and their well-being. People want to be educated. They want to know what's happening with their bodies. And so we had a total of 48 persons registering, and 43 persons completed the entire course. So that means they attended the full 3 days. Of the 48, 5 persons attended maybe 1 day, maybe 2 days, but 43 completed it in its entirety. So a little overview of the course content. So on day 1, we did Hypertension Explained. We covered salt and hypertension, and those were done by Sister Nadine Jubri and Mrs. Minerva Taylor Benjamin, respectively. On day 2, we covered stress and hypertension, which was covered by myself and Mr. Bamishile. And then we had Ms. Kalila Worrell, who covered understanding the medications used to treat hypertension. And then on day 3, we had measuring blood pressure, and this was done by Miss Vanessa Farrell. She is an external stakeholder, I would say. She's a health educator, Montserrat-born, who partnered with us on this project. And we also did recap an evaluation, and what I would say is a little graduation at the end. And we didn't just leave it there. At 3 months after the course, we did a follow-up with participants via a telephone interview. And the aim was to assess lifestyle changes, medication adherence, self-monitoring, and a willingness for further engagement. And that was conducted by Mr. Jones. Okay, so let's talk about the post-course evaluation, which was done on day 3 at the end. So it was a paper-based evaluation, and what we wanted to do, we asked individuals, to provide a rating on a Likert scale of 1 to 5 to assess their confidence in their abilities to manage their hypertension now that they've completed this 3-day course. We also asked them to identify which of the sessions that you saw before they found the most useful, so that we could learn what topics were of greatest interest to our population and identify possible areas for future focus. So let's say most people wanted to know about the medications more, then we could do an intervention around that, etc. We also asked persons to assess the ease of understanding of the course content, and we asked if they would recommend the course to other persons living with hypertension, because this is important for us to gauge areas where we are falling short, where we can do better and improve. And we also want to ensure that what we are doing is useful to our key demographic, which in this case is persons living with hypertension. So the results. So on average, we saw confidence in the capabilities to manage high blood pressure after participating in the course. So keep in mind that scale of 1 to 5, what we did was we averaged the scores. So confidence to make lifestyle modifications had a mean score of 4.18 out of a possible 5. Confidence to accurately measure blood pressure at home had a score of 4.68 out of 5. Logic and ease of understanding of the course material had a mean score of 4.68. And recommendation of the course to others had a score of 5 out of 5, which means all the participants found it useful and something that they think other persons can benefit from. Important to note is that 6.98% of participants expressed low confidence in managing their high blood pressure overall. And while you won't always win everybody over, it still means that we have room for improvement, and maybe this is not the best approach for everybody across the board. We also had 11.63% of persons who felt less confident about doing so independently. So they would have gone through the course, but they still didn't feel that they could do it on their own. So when we asked the participants as to which courses they found the most useful, which topics, understanding medications used to treat hypertension and stress and hypertension were the 2 most frequently mentioned. And just to say here, persons could select more than 1 course. Salt and hypertension followed, hypertension explained, and then measuring your blood pressure. So our epidemiologist at the time, Abby Harrison, she did her calculations. And what she was able to tell us was that hypertension explained and stress and hypertension demonstrated a positive correlation, which simply means that persons who found one session useful also found the other useful. Similarly, the sessions measuring your blood pressure and salt and hypertension also showed a positive correlation. On the flip side, or conversely, understanding medications used to treat hypertension showed a negative correlation with both stress and hypertension and salt and hypertension. So this result implies a clear distinction in the participant groups, where those who favored understanding medications were less inclined to perceive the other 2 sessions, stress and hypertension, and salt and hypertension, as useful or beneficial. So the 3-month telephone interview, this was conducted 3 months after completion of the course. And the inclusion for criteria here, we contacted persons living with hypertension only. So remember, we had 20 people who did not have hypertension. We did not include them. We also limited it to persons who completed the full 3 days of the course, And we were able to capture 21 of 33 persons. So some persons, we contacted them, but the phone rang out. Others, we had the wrong number, and one person migrated. So the aim was to assess if persons were able to incorporate the self-management principles and techniques into everyday life and assess willingness for further intervention. Another thought process around this was it's always good to have a refresher or a repeat. You know, even with ourselves, we might start off doing something good like exercise and changing our diet and we fall along the way, right? So this 3 month was also used as a reminder to persons to keep doing what you need to be doing. So the results. The first question was, would you be interested in participating in a focus group as a follow-up to this survey? And 95.2% out of the persons we called said yes, only one said no. We also asked, have you made any changes to decrease your salt intake? And again, we had 95.2% of persons, or 20% saying yes, and one saying no, they did nothing. Have you had any follow-up visits with your healthcare provider regarding your blood pressure? We had 76.2% of respondents saying yes, which is 16 persons. And this question, we were hoping for a higher number because 3 months was selected for a reason. When you go visit a health center, you get a prescription for 3 months. So within that time, we expected those persons to have gone back to their doctor, but only 76.2% had, meaning 5 persons did not. We asked them about their blood pressure control at home. They got a machine, they got a logbook, they were able to track. So we asked them, has their blood pressure measurements improved? And 76.2% said yes. We had 3 persons saying they weren't sure. And we had 2 persons saying no change. We also asked, has their ability to follow their medication plan improved? And we had the vast majority, 20 persons or 95.2% saying yes, it has improved. And 1 said no. So there's a question as to whether that's the same person. Okay, so the majority of participants saw improvements in their ability to follow their medication plan and have observed better blood pressure readings. Most persons said yes, they were actively monitoring their blood pressure and had follow-up visits with their healthcare provider. However, as I told you before, the ones that haven't, they're a group of concern that we need to figure out how to reach those persons. Dietary change was prevalent among the participants, and there's strong interest in participating in further focus group sessions. And again, it just shows that people want to be engaged, they want to keep learning, they want to be on top of their health. So the major conclusions, the findings demonstrate the positive impact of the hypertension self-management course. We can conclude that we had some success in enhancing participants' confidence, knowledge, and skills. The results also indicate that there are areas where further support is needed, particularly for people who feel less confident or less in control of managing their condition independently. And we also need to figure out how to reach those people who are struggling with routine follow-up visits. We need to try to identify what the problem is. Is it maybe the time of day that the clinics are open? Is it a lack of transportation to and from the clinics? Whatever the reason, we need to figure that out. And we also need to address persons who still have concerns about self-monitoring, so they aren't sure still how to measure at home. So recommendations, continuous engagement is important and further interventions may be needed for optimal benefit of self-management. And there are some studies that say you should really be doing it every 6 months. But in a society like Montserrat where we have limited staff, that's a little bit of a challenge. And recommendation 2, a longitudinal study of the blood pressures of the participants would be useful to provide a clearer picture of the actual impact of the course. If we could actually track their blood pressures over time to see how they're doing, that would be absolutely wonderful. So maybe next year somebody will do that. And just some acknowledgements here of the persons who contributed. And I really have to say thank you to Abby Harrison, who did a lot of the analysis for us, and Miss Vanessa Farrell, who crowdsourced to fund 50 blood pressure machines and logbooks, which the persons who attended the course were able to have. And she has done that again this year, and we will be having our next group in 2 weeks. So that's it for me. Any questions? I see one hand.
Is that working? Yeah. Hi, thank you for the talk. That was really interesting and really impressive that you managed to put on such a comprehensive course, because I think that we would very much struggle to have something so comprehensive in the UK. I just wonder if, going along with your second recommendation of doing like a longitudinal study, whether you would consider having a control group or a group with a like slightly less comprehensive intervention. So like, yeah, in the UK we probably would provide a leaflet or do like a brief intervention, just because 3 days is like obviously a very work intensive from your side of things. So I wonder if you thought about that. And the other thing I wanted to say is, was there any gender breakdown in who participated? Just because we've been talking a lot about men being very not very engaged in their health, and you've talked a lot about engagement in healthcare. So I wonder if there was any data on that.
Okay, so the first one, what we did think about doing was using the HIS system, newly installed, to track the blood pressures over time when the persons come to the clinics. But there's some work that has to go around that in terms of consent and whatnot. So it's surface level so far. You know, we would need to really go in depth to plan how we would do that. And the male breakdown, I cannot remember off the top of my head right now, but we definitely had fewer males than we did females. We had maybe about 4 males in totality. About 4 males, I believe. So, again, capturing the males is a challenge. But the thing is, for the group that went out to the radio, we had 1 male, and he was brought along. You can imagine how he was he was brought along. And the group from the clinic had the remainder of the males, and they did come, they did participate, but, you know, of course, the numbers were smaller than the females. You have a question here?
Thank you. Again, very interesting talk. In your sort of selection, both the sort of invited people and the people who came from the radio announcement, there's an element of sort of sampling bias, because those who come forward and volunteer for those sort of programs, they are the sort of people who are clearly concerned about their hypertension and want to make a difference. How can you sort of develop alternative strategies to try and reach those who aren't perhaps so actively engaging in healthcare and who wouldn't want to be the sort of people who would perhaps step forward for these programs?
Well, what we did, we asked the nurses and the district medical officers to review their clientele and look for persons who they can tell want the help, you know, and would be interested and willing to come. So that was the approach that we took with this. This year, we've asked for newly diagnosed persons in the last 365 days. So we've got that list. So that was the approach last year. This year, we're doing it a little bit different in terms of new diagnoses. But going forward, it's always a challenge capturing people who aren't interested. So the best thing we thought to do would be to personally invite. So the nurses, the DMOs would have spoken to them, and then I would have reached out. You know, sometimes you have to coax them a little bit, you know, tell them it's going to be a good time, you're going to have fun, it's going to be good, you know. So sometimes that approach, that personal approach is needed, but other times it just works to put a notice out on the radio.
Thank you.
Let's see another.
Hi, fantastic outreach program to the community to get people involved and engaged in the control of hypertension. 2 things. One, I was thinking that the medication group, the people who found the advice on medication more useful, these are the people who had already mastered the understanding of hypertension and stress associated with hypertension. So patients come with different levels of knowledge, and there is a group who's gotten it at various levels, and they really want to learn more about what are these medications really doing. So I think it's very useful across the board. The other thing I was thinking was that it would be nice, except to be very labor intensive, to capture your end goal, which is the prevention of complications of hypertension. So if this was a long-term ongoing study, you could capture whether or not these people had cardiac enlargement, ECG changes, cardiac symptoms. You could assess their stroke risk. So it could go on, but I think fantastic with what you've done, and I hope there's a budget to keep you going with it.
Okay, I'm looking at the budget makers. But thank you. The understanding the medication session was actually quite interesting, particularly with the group who were living with hypertension. They had quite a lot of questions as to how the medications impact their bodies. There was some where the pharmacist was talking about contraindications, and drugs that shouldn't go together. I remember one person, she was alarmed because I'm on these two things, and she was like, yes, I need to go to have a chat with my doctor. So the persons were really overwhelmingly engaged in that session, and we did have conversations after about having some more further intervention with the pharmacy unit in terms of how we can better educate people when they come to the pharmacy about the medications that they're taking. But they're having a little bit of staffing challenges, but hopefully, that's something that would be incorporated there. Is that it? Yes, thank you.
Yes, thank you very much, Mrs. Maloney. Thanks for sharing. It's always good for us to assess the interventions that we put in place so that we know how to move forward and where we need to place our focus. And I was thinking in terms, because we have limited staffing resources, we could probably look at the virtual options so that we don't have to always be in face-to-face or in the same room to share information. So if we could create some videos and so forth so the patients can, who have already participated in the course, if they forget things, they could go to this particular portal and know, how to do this, which medication doesn't go with that. So we need to try to use more virtual technology to help us. Yes? Okay, so now we're going to move on to our final presentation in the third segment, evaluating the impact. And we're going to call on Mrs. Manerva Taylor Benjamin to do her presentation.
Good afternoon. I'll ask your indulgence. I know lunchtime is pretty close. When I saw the agenda, I was wondering, why am I the last? But I think, as the good book says, all things work together for good. Because at the end of the presentation, I hope that your lunch choices would be a lot better. All right. So the study, and I must say here that some studies are better participating in than presenting. And this is one of them. So this was a study to basically conducted over 6 weeks to empower staff to take better care of their health. And the rationale for doing the study was that the evidence is there that any change in lifestyle, any modification, changes in lifestyle and lifestyle habits would impact health in both the long and the short term. Other thing too was that if we are to advocate these kinds of behavior changes, we ourselves must be testaments to those kinds of behaviors. So that was the rationale for the study. And it was to help. Staff was complaining, and it was an idea to help them jumpstart prioritizing lifestyle modifications as part of their daily living. So in April of 2023, we launched a 6-week challenge. And basically, it was to help persons to reevaluate their lifestyle and to become more active, physically active, looking at what they ate and to just look at overall health in terms of management of stress and that kind of thing. So the study had 3 major components: physical activity or exercise, there was a nutrition component, and there were some aspects of wellness. So the aim of the study, as I said, was for persons to take charge of their health. Basically, the objectives were to expose individuals to various types of exercises and to look at other health activities such as water intake and food intake, and to compare the different health and wellness parameters before and after the program, and to determine if the activities would cause an impact in terms of sustaining long-term changes, and to see if there's a link between, sustaining lifestyle changes that improve health outcomes. So that was it. So the study design was pre- and post-interventive study. The study population was all the participants that completed the 6 weeks of the challenge. And those persons who did not complete the challenge in the entirety were not used as part of the analysis. So the method data source, we did some anthropometric data. And as I said, data was collected before and after. So anthropometric mean height, weight, BMI. We also did waist circumference. We did blood pressure. What else did we do? Okay, that's basically it. And then at the end of, exactly 6 months after the study, we did a post-survey to determine whether persons were able to maintain some of the changes that were made in the 6 weeks. What was that, Listra? Oh, okay, all right. So the analysis, the participants were described based on age and gender. As we said, the measurements were taken before and after, so we used the peer t-test to do the blood pressure, and where there was normal distribution, and we used the Wilcox ranked some tests where there was abnormal distributions, and we did the analysis of the survey. Of course, ethics clearance had to be had because, especially using the information for persons. So basically, just to give an overview of how the challenge was done, persons were invited to form teams, and teams were a maximum of 8. And we allowed persons, because we wanted to, it was health, but we wanted to give other persons exposure. They were allowed to have 2 persons outside of health to be part of their team. So we did a pre-challenge survey and assessment, and we gave a few incentives. And the incentives basically was one of the limitations of the study, of the challenge. So we tracked and we recorded things. Each week, persons had to do different things. And the session ran for 6 weeks from April 10th to the 21st of May. So basically, we divided the challenge in 3 segments. Segment 1, we focused mainly on fitness and water intake. So during that first section, persons were encouraged to do 30 minutes of physical activity by themselves. We were encouraged, we had 1 scheduled group activity which all persons were expected to attend. Persons had their pedometers, and they were expected to clock at least 6,000 steps and have at least 16 to 24 ounces of water, pure water, per day. And then within that exercise, there were certain targeted exercises. So that first week, we were asked to do jumping jacks, and each week you added, and the amount, the intensity, and the amounts increased as the weeks progressed. Okay? So week 2, for the second segment, we introduced fruit and vegetables. So persons were asked to, and we added the sugary drinks and beverages and snacks. So during that period, persons were asked for at least 2 to 4 times of the week not to have any sugary drinks, beverages, or salt or sugary snacks. And they were asked to consume 4 to 5 servings of fruit and vegetables. Of course, the water consumption increased and the pedometer steps increased also. Yes? So this was the analysis. Of the study, only 41 persons, I think 31 persons completed. No, this is male and female. 81%, as you see, were females. with a median age of 38 and age ranging from 18 to 74 years. 31 persons completed the challenge, and most of them being females. Most of the males that dropped out were younger males who had more likely they were healthy on the healthier version. So those were the men who participated. So they had better body fat percentage, they had low BMIs and so on. So I guess when they realized what the challenge entailed, they did not feel inclined to complete it. Right? As I said, 31 persons completed, and we had measurements for them for before and after. In terms of the persons who completed, the median age was 43, and the age range was between 22 and 57. And what we found is that there was some weight loss, right? So there was weight loss ranging from, the mean weight loss was 4.5 pounds, and the range ranged from 0.4 pounds to 11 pounds. Pardon? Okay. In terms of body fat percentage, we did see a decrease in body fat percentage. So the median body fat percentage reduction was 2%, and it ranged from 0.5% to 10.8%. As other parameters, the waist circumference, we did body percent fat and BMI, we saw significant reductions in these levels over the 6 weeks period. So we saw persons' waist circumference, there was a decrease in BMI, and there was a decrease in body fat percentage over the 6 weeks period. Similarly, with blood pressure results, both systolic and diastolic, there was a decrease in meaning decrease, and it was significant in their results. The 6 weeks after the follow-up, we gave persons some time. After the challenge, we gave persons some time. And as I said, 6 months exactly after the challenge was completed, we did a survey. We had a 97% response rate, and it was basically quantitative in that persons were just asked to, and that in itself persons could have, inflated. But the general picture was that persons found that there was a positive impact on their health. Most of the respondents thought that the challenge did make a positive change to their health and to their outcomes. Only one person said that they didn't feel the challenge perceive that the challenge did anything. Maybe the person was already exercising, maybe the person, so we don't know. Since the challenge, persons thought that, most of them still continued in physical activity. 60% of them rated it 8% or 8. They were given a scale of 0 to 10 and the rating. So 60% gave a scale of 8, saying that the exercise, the physical activity levels were increased or maintained. Okay, in terms of walking, some persons were doing a bit more walking. Some persons actually went out and bought additional step devices. So they were, rather than during breaks, they were doing a little more movement between desks and so on. So this was just the response. So persons were more aware that they had to be moving. So 47% maintained their step counts in the 6 months following. 67% maintained their physical activity level. So some of them were still doing some kind of aerobic, some of them were still doing some of the activities that we introduced them to during the challenge, maybe skipping and strength training and that kind of thing. All right. So in terms of diet, 63% of them said they were following or maintaining some of the changes made. So they were having their fruits and vegetables. They were making sure that the color was represented each time. They had actually reduced their sugar intake, and the fat intake of meals. And a lot more persons were having meals prepared at home rather than having meals prepared outside meals. So those were some of the positive things. In terms of water, 83% of them said that they were maintaining it. So we see, and a lot of them were having less sugary drinks and beverages. Okay, so we see that as a positive. I see a lot of people walking around with their water bottles still, so we can attest to that. These were just some of the factors that, motivated them for continuing on a healthy lifestyle, with the healthy lifestyle initiatives, practices. They have a family history and they don't want it to be repeated with them. They want it to be stopped with them. They want to be healthy for their family. They want, to just have that general weight loss and that just general feeling of wellness. In terms of the barriers, because we asked what were some of the things that would have been preventing them from really and truly, fulfilling the carrying out or maintaining the activities. And time, as you can see, time was one of them, and lack of motivation. Well, money. I guess money came in here when we spoke about the fruits and the vegetables or eating healthily, and lack of motivation and that kind of thing, lack of support. So these are some of the highlights. I promised that I would just give some good sides, because there were some other things that we could have shared, and some additional comments. Persons were motivated by their peers, so having that person pulling them along, that buddying system actually helped persons to complete. And those who completed the challenge, everybody was basically calling on each other, asking them, so there was an accountability system, and that is very important. We found that it was important in the completion of this study. So what would have been interesting if the groups, because some groups were on top, there was on A game in terms of motivating and encouraging each other. So it would have been good to see if there's a difference in the parameters with groups who really had that, because some groups really went over and above in terms of motivating each other to do activities. Participants appreciated there was a variety of activity. The goal of doing that was to, at the end of the day, persons to choose the ones that they were comfortable with and comfortable in sustaining. So we had activities ranging from water aerobics, dance exercise, what else we did? Groups. We had hiking. We had so what basically the aim of it was for persons at the end of the day to choose something that they could have sustained and maintained for a lifetime. All right. The conclusion, so basically the results were consistent to the findings in that any change in lifestyle modification would see some improvement in the health indices. The peering and budding system helped with participation and compliance. Also to giving diversity in terms of physical activities help persons, it reduces boredom and help persons to become more engaged. And also too, we found that having access to resources, because in addition to just telling persons what to do, there was that element of providing additional resources to persons in terms of they were experiencing hiccups during that challenge. So making sure that the support and the resources are available to persons would ensure that the lifestyle habits are maintained. So recommendations as the leading agent, us, we need to really get up and get out and support our staff so that we can be, as I said, testaments to this. We can teach through our lifestyle, right? And then we can encourage other persons, other agencies, other ministries to really adapt it as part of their employment or their employee policy. And as I said, incentives help, but you have to know when and how to use them, because they can help, but they can also deter. Because a lot of persons, what we found, a lot of persons registered. We had massive registration because of the incentives that we were giving. But then when it actually came to, fulfilling the obligations, persons weren't. Another thing too that was probably was an inhibitor, we tried to work around the shift system, but because of the shift system that we worked in health, we work in health. Some persons were not able. We tried, but it was not always convenient for persons to attend, especially the group sessions. So that is something that we probably need to look at going forward if we are to repeat the activity. Or if we are to repeat the activity. All right, so I just want to thank at this time, I must publicly thank Gwethlyn and Alice for their support and their help. But other than that, we have some persons who have been instrumental in providing both financial and other resources in completing the challenge. So I just want to express my thanks here.
We now welcome questions for Mrs. Taylor Benjamin.
I'm not sure what time today it is either, but just to say to you, thank you for being an advocate for good health throughout the ministry for all the years. I would have known about you before I joined health for that. Join health and you're still continuing to do it. So I want to thank you for helping to lead the way for this initiative and to thank everybody who participated. It was good to see the results. Good day, all. As a participant in this health challenge, I must say that I did enjoy it. And for me, it was something to get away from that daily routine of work and going out, going on the beach, relaxing with your colleagues, having fun, and of course the challenges whereby you want your group to win. And I used to look forward very much for this. I'm a person who loves dancing, and I mean, I won't miss any dance at all. I could miss anything else, but for the dancing, I would be there. And secondly, I want to compliment Monelva, because even after we finished the challenge, persons still felt that they needed more. And so we got together and still continue even after the 6 weeks. And even now and then you see some messages coming in, encouraging persons and asking who is interested in doing certain health challenges. So it was really good, and I do recommend that the Ministry of Health can put on another one.
Yes, I think this is a really good... Yeah. Oh, good. I think this is a really good study. I was just wondering or curious about where did the 6 week, the number of 6 come in? Because as a psychologist, I'm thinking, how many weeks does it take to form a habit?
The study said 12 weeks, right. But because of, we were just trying to jumpstart,
yes.
As I said. We did 6 weeks, but right. As Nurse Mead said, some of us continued to the 12 weeks.
Absolutely, because I know in the research it's about 6 to 12 weeks for a habit to be formed.
And between 8 and 12 weeks, correct. You'll see. But we didn't want to go to 12 because we didn't want persons to
drop out because it's a bit long.
And so on. So we chose 6, but those who actually saw the benefits of it actually continued for the 12 weeks. So it'd be good to see what the measurements were at the 12-week period.
Right.
Some persons did, but we didn't collect everybody. But it's just to compare, the 6 and the 12.
And as we all know, health and fitness is also a matter of psychology and mind over matter. Psychology has a lot to contribute in the area of this. Right. So I'm thinking about, as part of the intervention, I'm a bit curious as to what would it have made a difference or a greater impact if some CBT, for example, was added in there in terms of motivation and helping clients to change their thoughts, their unhelpful beliefs, and also to provide some positive self-affirmations like day-by-day quotes, that kind of thing. So an injection of psychological concepts to also boost the motivation of these people who are going forth in this 6-week course. I'm just curious about the role of psychology.
Behavioral change does require that kind of intervention. So
Right.
Something worth considering. Thank you.
Just real quick, since we spend so much time talking about mental issues, and Mrs. Daniel Bourne did mention about capturing persons that probably wouldn't have come out and say, I have a mental issue, I'm probably suggesting that next time you do this, you could probably do a questionnaire about that. Because, it would be mental health for the persons who are participating, just to see where they're at before. And
but we didn't ask about mental health. We just asked about, what was the lifestyle things that they wanted to achieve and that kind of thing.
Right, because if you probably added that, because probably a lot of persons really are suffering in silence. Mm-hmm. So, I'm sure there would have been that additional benefit that anybody could say with the release of endorphins with the workout. Sister just said that she looked forward to that away from the day-to-day monotony of just work, home. She's going to meet her friends. She's going to be in a challenge. There's going to be a competition, and she's ready to dance. Just to see the general trend in terms of improvement with mental health in addition to. So you could probably look at that next time as well, see how your staff, you have a happier, healthier staff at the time, and, document it, yeah.
Yes, I just wanted to make one comment around one of the motivating factors to be in the challenge was the group approach, that you weren't doing it in silo, you were doing it with others. And we spoke a lot today about getting men, to come out, and maybe that's one of the techniques that we all as health workers in the room could think about in groups. Well, I'm talking about things unique to men, so men's groups, even with the hypertension in terms of the self-management, that could be another thing that we could look at, because really for me, and just as Nurse said, a lot of it was the group motivation, to come out and to do it. So just future thoughts for us as we plan future interventions, maybe look at support groups and stuff like that so that we can achieve similar results. And thank you, Manelva. The challenge was lovely, and I'm still on it.
Just to add as well, mindful eating, because I think that actually has a lot of useful contributions to fitness and diet. Mindful eating, and that could be easily taught.
And we'll start from now.
Yes.
Yeah.
Very good program initiative and report also. I know years ago you had a very comprehensive program which targeted children. Are there any prospective plans to bring that on stream? Because we don't want to leave out our children.
They're all looking at me. You mean the school health after? Yeah, there are plans. Yes, there are plans. There are plans, but
all right, so we say thank you to Mrs. Manelva Taylor Benjamin for her report on the health challenge, and I'm happy for the input that the audience gave, sharing their experiences. And I myself can attest to the camaraderie and how everything was vibrant and so forth. It definitely was a good 6 weeks. I commend my colleagues who are still on track. And for those of us who have slipped, slided, and rolled over the hill, I hope that our return would be speedy enough, and we look forward to Mrs. Benjamin and her team, for them to put back on a similar challenge. It is clear that she's good at this, and her years of experience as the nutrition officer is shining through. So thank you again, Manelva. All right, so we have made it to our lunch time. Yes, it's now time for lunch. And lunch, we have 1 hour. It's still a working day, so we have 1 hour for lunch. So please ensure, if you're going to be with us for the afternoon, that you're back here before 2 so that we can reconvene at 2. All right? Thank you, guys, and enjoy your lunch.